We now request all of you to please stand for the Ramaiah anthem.
We'll now have the invocation song followed by any lighting of the lamp. We request Dr. Radha, chairperson of the invocation.
We request the dignitaries to kindly come forward to light the lamp. जय जय हे भगवती सुरभारती तव चरणों प्रणमामि। जय जय हे भगवती सुरभारती तव चरणों प्रणमामि। नाद ब्रह्ममयी जय वागेश्वरी शरणों ते गच्छामः। त्वमसि शरण्या त्रिभुवनधन्या सुरमुनिवन्दितचरणा। त्वमसि शरण्या त्रिभुवनधन्या सुरमुनिवन्दितचरणा। नवरसमधुरा कविता मुखरा स्मितरुचिरुचिराभरणा। जय जय हे भगवती सुरभारती तव चरणों प्रणमामि। आसीना भव मानस हमसे उन्दतु हीन शशि धवले। हर जडतो कुरु बोधि विकासं स्मित पंकज तनु विमले। जय जय हे भगवती सुरभारती तव चरणों प्रणमामि। ललित कलामयी ज्ञान विभामयी वीणा पुस्तक धारिणी। ललित कलामयी ज्ञान विभामयी वीणा पुस्तक धारिणी। मतिराताम्नो तव पद कमले मतिराताम्नो तव पद कमले। ऐकुण्ठाभिषवारिणि जय जय हे भगवती सुरभारती तव चरणों प्रणमामः। प्रणमामः प्रणमामः। Now we request all of you to kindly stand for the Ramaiah. Thank you, dear dignitaries, for a wonderful start to the program. And thank you, Dr. Rara, for the invitation song. We now request Dr. Sheikh Mohammad Aslam, Professor and HOD, Department of General Medicine, to kindly give the inauguration and welcome address.
So, good morning, everyone. Respected Chief Guest for today's CME, Dr. Shalini Muni Ma'am, Principal and Dean, Ramaiah Medical College, Dr. President, Ramaiah Memorial Hospital, Dr. Sumit Raisen, Professor and Head of Microbiology from AIMS Mangalgiri, Dr. Jayanti Savio Ma'am from St. John's Medical College, distinguished speakers, delegates, faculty members, and my dear friends. On the occasion of World Antimicrobial Awareness Week, that is November 18th to November 24th, and birth centenary of our beloved founder chairman, late Karma Yogi, Dr. M.S. Ramaiah, the Department of General Medicine, in collaboration with Hospital Infection Control Committee, welcomes you to this CME on Antimicrobial Awareness, current status, and action plan. Now, as you all know, antimicrobial resistance is an urgent global public health problem and a threat, and this is associated with approximately 5 million deaths annually. Antimicrobial resistance is increasing globally, and this is due to increased prescription as well as increased dispensing of antibiotics. And coming to India, antimicrobial resistance has become a great threat. Now, this is because of high burden of infectious diseases in India, higher antibiotic usage, self-medication, over-the-counter usage of drugs, and lack of awareness. So, one of the important tools for combating this is Antimicrobial Stewardship Program. So, to throw light on these burning issues, today we have eminent speakers from prestigious institutions who, with their vast experience in their field of expertise, will be throwing light on these issues. So we'll be having many enlightening lectures and discussions on various topics across the spectrum of infectious diseases, which include topics like interpreting cultures and antibiograms, treating multi-drug resistant infections, antimicrobial stewardship program, infections in critically ill patients, and many more. So once again, I wholeheartedly welcome one and all for this CME. Hope all of you will have an excellent experience and a rich academic feast. Thank you.
We now request our principal, Ma'am, to felicitate Dr. Aslam. Sessions now, I request the dignitaries to take a seat in the front. Now let's start with our first session for the day with this pharmacokinetics and pharmacodynamics of the antibiotics. The field of physician, our esteemed speaker, Dr. Hon'ble, who is the head of infectious disease and infection control in Aster DM Healthcare, who's live online in Kochi. Unfortunately, for circumstances, is joining us online from Kochi. Hearty welcome to you, sir, and we are delighted to have you with us. Also, now welcome the chairperson for the session, Dr. Vijay Ragaj, who is a senior professor in the Department of General Medicine, and Dr. Ananda Eshri, professor in the Department of Oncology. Dr. Vijay to kindly introduce Dr. Hon'ble.
Good morning. It gives me great pleasure to introduce the first speaker of the day. Dr. Hon'ble is a senior consultant and the head of infectious diseases and infection control at the DM Healthcare Kochi. He's a physician with over 15 years of experience and specialized training in the management of infectious diseases and infections in hospitals. His special interests are tropical infections, fever of unknown etiology, infections in the ICU, and HIV medicine, and also antibiotic stewardship and cost-effective evidence-based infection control. Anup is a fellow of the Royal College of Physicians and fellow of Infectious Diseases Society of America. Dr. Anup is an international ambassador and research grant winner of the Society of Healthcare Epidemiology of America. He is Healthcare Asia Management Award winner twice, 2016 and 2018. He is also a member of National Infection Control Guidelines Committee. Welcome, sir, to this session.
Thank you. Just give me a moment to share the screen. So, is my screen visible now?
Yes, sir, it's visible.
Thank you. So, good morning, all. So, we are starting the day with a bit complicated. Yeah, my slides are moving, right?
Slide show, if you could advance the screen.
Yeah, is it moving?
Sure, that was now you can continue.
I can't hear you well, but can you just confirm my slides are moving?
It's moving, it's visible, sir. Please go ahead.
Yeah, okay. So what I was initiating was that the PKPD topic a bit complicated to start the day. So however, the idea for today for me is that for the initial couple of minutes, I'll give you a very brief outlay of the theoretical part of it. And then we will come to 4 or 5 core principles which we apply in our day-to-day practice in management of infections. So that's the way the day is expected to progress. To start with, we realize that there are multiple factors that affect or impact the treatment of an infection. The antibiotic or pharmacokinetics or dynamics is not the only thing which matters when you treat an infection successfully. There are host-related factors. The immune response of the host plays an important part. That's not our topic for today anyway. We have pathogen-related factors, the resistance and the MICs of that, and based on cultures, which Dr. Sumit will be speaking about next. We have the antibiotic choices and selection part and how you use these drugs, and that's primarily my role today to discuss this third aspect of the dosing of antibiotics and how that would influence your antibiotic management. Okay, so to start with, all of us should understand this. This is just one among 3 aspects: the host response, how the pathogen and what kind of pathogenesis is, and then you have an antibiotic. And we are talking about just one part of this triangle, the antibiotic now. Now, when you talk about pharmacokinetics and dynamics, it's a spectrum. It's the 3 major components of pharmacokinetics are absorption of the drug, the distribution of the drug into various body compartments, and how the drug would be eliminated from our body, hepatic or liver or kidney or some other way. So it's basically 3 major aspects: absorption, distribution, and elimination, all of which primarily determines the drug concentration at the site of infection. So what happens in the pharmacokinetics in terms of absorption, distribution, and elimination is expected to culminate into the core aspect of what is called as drug concentration at the site of infection. And that's where the success of the therapy is determined, right? So that's how it reaches there. There are various factors that would affect the pharmacokinetics, and based on these, we often modify our doses. And that's what we are going to look at now. And what are these variable factors and why we should be aware of this variability and what should we do to address this variability. Moving forward, once you have the drug concentration at the site of infection, the next important thing for the drug is to have its efficacy, right, in terms of inhibiting the bacterial multiplications. So for this, we come to a value called as minimal inhibitory concentration, or MIC, which is on the graph what you see on the right on the dotted line. So what that primarily means is that the antibiotic which we give need to reach a certain concentration at the site of infection, which would be above the level which is required to inhibit the multiplication of that bug, okay, of that bacteria. So that's minimal inhibitory concentration, and we need to go beyond that. That's what the shaded region in this shows. So this will ensure that you have the effect of the antibiotic. So that's the last box in my slide, that is the drug effect. So you have the pharmacokinetics determined by absorption, distribution, and elimination. Based on this, you have the drug concentration at the site of infection, and based on the drug's concentration, you have the drug effect. So this is how the whole spectrum would follow. Now, based on the pharmacokinetic and dynamic aspect, we divide the antibiotics into 2 or 3 major categories. So why do we do this division is because to understand how to dose certain drugs in certain way. Okay. So one of the classifications from the pharmacokinetic perspective is dividing antibiotics into hydrophilic antibiotic and lipophilic antibiotic. Why is this important? This is because the volume of distribution of these drugs vary based on whether they are hydrophilic or lipophilic, and based on the volume of distribution, your dosing strategy changes. Okay, and I will explain how the dosing strategy changes. So examples of hydrophilic antibiotics are all your beta-lactams, your aminoglycosides like gentamicin, amikacin, etc., your glycopeptides like Vancomycin, Deco, your linezolid and colistin. So for these, usually it is predominantly renal clearance. They have a low intracellular penetration. However, when you use them in the ICU in the initial phase, especially in a sepsis patient in the starting 1 or 2 days of early sepsis, these are affected by increased volume of distribution. Okay. So being hydrophilic, while the patient is in sepsis, there is increased volume of distribution. These are affected by increased volume of distribution, and therefore their doses or dose requirement goes up in these situations. So it is important for us to understand this aspect, that hydrophilic antibiotics are more affected by volume of distribution in the ICU patients, and therefore their dosing needs to be on the higher end while we use them in the ICU. For the lipophilic antibiotics, even in the ICU setting, their volume of distribution is mostly unchanged, because to start with itself, they work at a high volume of distribution. So for your fluoroquinolones, macrolides, clindamycin, etc., tigecycline, and all these drugs, they are lipophilic. Even in an ICU setting, their volume of distribution is mostly unchanged. Hence, usually there is no requirement to dose them higher than what is recommended by the renal functions. Okay, so this is the first important aspect which we need to understand about the pharmacokinetics of antibiotics. The next aspect is about the site of infection. So we spoke that the impact or effect of antibiotic is based on the concentration at the site of infection, not necessarily the blood. So if the infection is in the blood, that's fine, but often it is in the lung, it is in the brain, it is in the soft tissue, etc., etc. So what matters in killing or inhibiting the multiplication of the bug is how much of this drug gets into the site of infection. Now, based on different site of infection, there is again differences in the pharmacokinetics. If it is only blood, especially in the sepsis scenario, you have enhanced renal clearance, and you need to figure in or add a component for expanded volume of distribution, and hence the requirement for what is called as a loading dose. Okay. So in primarily blood infections, which we assume when we have a sepsis septic shock, the requirement for a loading dose is present. This is because they have an expanded volume of distribution and also increased clearance. Lung also, especially ventilator associated pneumonia, etc., where the concentration in epithelial lung fluids is important, we tend to give beta-lactams and other antibiotics at a higher dose. Somebody has a soft tissue infection like skins and soft tissue, necrotizing fasciitis, cellulitis. Here, if the patient is obese, it would increase again their volume of distribution, and we need to increase the dose in an obese patient in this instant. Bone and CNS are two areas where the permeability or the ability of the antibiotic to get into that site itself is poor, and therefore these are the areas where we give higher doses with or without prolonged duration of treatment. Okay. So couple of key points to take back from this is that the site of infection often determines the dose. It determines the dose by impacting the penetration or ability to achieve concentration within the site. Sites like CNS and bone have poor permeability, hence they need increased dose. When we suspect a bloodstream infection, you require a loading dose because of expanded volume of distribution and faster clearance in the septic patients with bloodstream infection. Lung, it is recommended, especially in pneumonias, ventilator-associated pneumonias, to dose on the higher side. And in specifically soft tissue infections, when you handle obese patients, again, you need to dose at the higher side. With worsening sepsis, once your multi-organ dysfunction sets in, a whole lot of complications happens from the pharmacokinetic perspective. You have GI dysfunction, somebody is in shock, the blood perfusion is going to be to the other visceral organs, the body is going to take it out of the gastrointestinal tract, hence your GI dysfunction happens, decreased absorption of all enterally administration medication, so you can't give probably anything orally at that time. There is tissue hypoperfusion. If blood itself doesn't get well into the tissue, the antibiotic which you give IV also will get in less, hence it might result in underdosing. There could be hepatic dysfunction, where a couple of protein binding of highly bound drugs can come down. This will again reduce in underdosing, and it may reduce the metabolism of certain lipophilic drugs, and it would increase the levels of that, and it could result in overdosing. Similarly, renal dysfunction, it will reduce the elimination of hydrophilic drugs, and if you give normal doses, it might result in overdosing. So you see that with organ dysfunctions, the dosing becomes complicated. Often we need to and review it on a day-to-day basis to understand when to give higher dose, when to reduce the dose. So the rule of thumb mostly in these cases is that somebody with multi-organ failure and shock, we do not use enteric antibiotics anyway, that's a given. For the first 24 to sometimes up to 48 hours, we go with normal dosing of antibiotics irrespective of the renal dysfunction to adjust for augmented renal clearance. By day 2, day 3, we look at what renal replacement therapy is happening, whether it is intermittent dialysis, whether it is CRRT, whether it is low efficiency dialysis, etc. And then we adjust the dose based on the renal replacement therapy. So in multi-organ failure, what we need to remember is that for first 24 hours or so, give loading dose, give normal dose. Following that, reassess the organ functions, reassess the hypertension, reassess the renal replacement therapy, and then go for the adjustments accordingly. Otherwise, either way, you may end up either underdosing or you may end up overdosing. Now, slowly spilling over to pharmacodynamics, we already had a brief look at this graph where we saw that on the x-axis, you have the time after administration of antibiotic. So what you see on the x is the time after administration of antibiotic. On the x-axis, you have the concentration of antibiotics after administration. And what you see as the dotted line is what we called as the MICs, or minimal inhibitory concentration, at what we discussed, what the level needed to block or prevent the multiplication of bacteria at that level. So we know that our antibiotics need to be at higher than this MICs. So there are two ways of achieving this levels of antibiotic higher than MIC. You can aim for a peak or the maximum concentration of antibiotic above MIC, what is labeled there in green, the top as peak bar MIC. So you might give a large dose of antibiotics together that you get a very high concentration at a point of time and then it just goes down. Or you can aim for keeping the antibiotic at a higher level for a long time by giving multiple doses or by giving prolonged infusions. So that's called as time above MIC. So overall, when we look at the antibiotic effectiveness, we divide them into 2 or 3 groups. Okay, one classification we already looked at, that was the difference between lipophilic and hydrophilic. Now the next classification of antibiotics is based on their efficacy parameters. So what are these efficacy parameters? It can be 3. One, it can be based on the peak above MIC, meaning how much concentration the antibiotic achieves when you give the dose above the MIC. It's just the amount of antibiotic at one time. It is not about over time. It is the amount of antibiotic you reach at one time. 2, it might be time above MIC. So that is about how long the antibiotic remains above the MIC during the day or between the dosing interval. The third is what is called as area under curve. That is the full form of AUC, area under curve. So this looks at the overall antibiotic exposure. So it looks at the peak and it looks at the time and calculates the area. So it is overall antibiotic exposure. So you have three groups. You have antibiotic which act based on peak, antibiotic which act based on time, and antibiotic which act based on exposure. So what are they? The time-dependent antibiotics are penicillins, cephalosporins, carbapenems, macrolides, clindamycin, and linezolids, etc. The idea is to have maximum duration of exposure. And how do you achieve that maximum duration of exposure? By more frequent administration, like penicillins, you give 4th hourly, 6th hourly, or prolonged dosing infusions, like meropenem, you give after 2 hours, 3-hour infusion. Okay. So that's the basis of handling time-dependent antibiotic. Concentration dependent are aminoglycosides, fluoroquinolones, phosphometrozole, colistin, etc. Here you need to maximize the concentration, and here what we give is infrequent doses, looking at a single, the whole daily dose is given as a single shot so that it achieves the peak. We are not bothered about the time. Then you have concentration dependent antibiotics, predominantly which we are talking fluoroquinolones, etc., where the idea is to maximize the amount of drug exposure. And here we try to give the maximum dose possible within those 24 hours, either once or twice a day. This is example of levofloxacin or ciprofloxacin. Now, in the graph, it looks very simple, but in terms of clinical application and clinical impact, the MIC-based decisions are not that simple. It is not 1 + 1 = 2 kind of equation in real practice and in patients. So there are a lot of complexities in that. So one complexity is that when you talk about time above MIC or etc., it is often drug bug specific. So even for cephalosporins or beta-lactams, you see that for different bugs, for gram negatives, the time above MIC is different. For gram positives, the time above MIC is slightly different. For some, it is you need to have 95 to 100. For some, you need to have only 60 to 70. For some different kind of infections, for meningitis, you need to have more. For just a pneumonia or a skin soft tissue infection, you need to have less. So even though broadly, when we say time above MIC for beta-lactams, etc., we need to realize that how much time above MIC? Is it 50%? Is it 60%? Is it 100%? Depends upon the kind of infection, the kind of bacteria, and the kind of drug. This is a similar graph for also a slide also for aminoglycoside targets, that they have a small variation in depending upon the different bugs. Now putting all this together, the antibiotic class, that is it concentration dependent, time dependent, etc. The pharmacodynamic parameter, that is, do you want the peak or do you want the time or do you want the exposure? Then you have the clinical optimization strategy, right? So in practice, how do you implement this theory? So for concentration dependent, as we mentioned, we implement it by giving a high once daily dose. For time above MIC, we implement it by giving either multiple intermittent doses or continuous or prolonged infusions. Okay, so this is the clinical application of this theory of MICs and PKPDs, what we looked at. Remember that all these data or most of this data.
Yes, sir. Yeah, you can just switch off your video and continue the talk, sir.
Sure. Just a minute. Hello?
Sir, there's a problem with the transmission. If you can switch off the video, it will be better.
Yeah, sure. Is it better now?
Yes, sir. Definitely. Thank you.
Okay. Yeah, so what we are discussing is that all this, what we looked at, what we reviewed, is mostly based on in vitro and in vivo experimental models. Okay. And we know that there are a lot of limitations when you look at models. And hence, as I was discussing when we started, it is not often a one-to-one calculation. It's not that 1 + 1 = 2. Often what we see here, its translation into clinical practice becomes difficult because of this dynamics, what happens in clinical setting. Okay. However, going forward, we will look at 5 most commonly used applications of this PKPD. Okay, so we very quickly, the theory aspect we have seen, we know that antibiotics can be divided into lipophilic and hydrophilic, and based on that, the dosing varies. We know that antibiotic can be divided into concentration dependent, time above MIC dependent and AUC dependent, and based on that, again, our dosing varies. We know that antibiotics, the site of infection is important, and based on that, the dosing varies. Now we'll try to look at what are the clinical applications of all these. So how do you use this PKPD in clinical practice? There, I have picked up 5 major ones with maximum evidence. Though there are a lot of dosing strategies, I have picked up 5 aspects which has got maximum evidence in using PKPD in clinical practice. The first is looking at prolonged infusions for beta lactams. Now, this was published last year, and this is a review of all the systematic reviews. What it concluded was that in critically ill, okay, so where the time above MICs, volume of distributions, etc., are key factors in achieving clinical success, prolonged infusions of beta lactams have a favorable clinical outcomes. Okay. What you need to remember is that the systematic reviews have concluded this in a subset of population, only in the critically ill. Hence, this is not a recommendation for routine practice of prolonged infusions, primarily because in the wards and all, you have resource requirements in giving prolonged infusions. We may have issues with stability of the drugs in the room temperature in Indian setting. So putting this together, and the take back from the systematic reviews is that in the critical ill, in ICUs, probably it is a good idea for you that when you use beta lactams with piperazine, tazobactam, or meropenem, to go for prolonged infusions. The next most evidence-backed aspect is about aminoglycoside dosing. So for aminoglycoside dosing, the standard of care now is once daily dosing. The whole daily dose calculated as per body weight and renal clearance is given as a single dose. So what you see in the table is a summary of all studies which compared nephrotoxicity vis-a-vis single dose vis-a-vis multiple daily dose. You see that for all the scenarios, the single daily dosing of aminoglycoside had less renal toxicity compared to multiple daily dosing. This was extremely predominant in gentamicin and not so evident or not statistically significant for amikacin. So for basically amikacin, they could not show a major difference in renal toxicity with single or multiple dosing, but with gentamicin and netilmicin and others, they did. And hence, it is an opportunity for us to reduce nephrotoxicity and get better efficacy by giving a single daily dose of aminoglycoside. However, there is a caveat that this has not been evidently proven when we use aminoglycoside for synergy to cover gram-positive infections like staph prosthetic joint infections, endocarditis, or enterococcal endocarditis, etc. Here, still the multiple daily dosing is recommended. The third important clinical application is about higher dosing in septic patients. So this we discussed at length when we were looking at the volume of distribution and pharmacokinetics in sick patients. So we understand that in the early phase of sepsis, there is something called as augmented renal clearance irrespective of the creatinine value. And even when we look at certain renal replacement therapies like CRRT, or sometimes when the patient is on ECMO for lung support, the dosing of antibiotic requirement goes up significantly. So hence, do not dose the antibiotics in the ICU patients solely based on their creatinine value. Look at the mode of renal replacement therapy, any adjuvant support systems like ECMO, and also remember that in the early phase, because of augmented renal clearance, you need to give higher dose. So this is just a snapshot of what happens. So you have increased volume of distribution due to endothelial damage and capillary leak, and you have increased creatinine clearance due to increased cardiac output and use of vasopressors, and you have increased vascular permeability. So all of these results in the change in the physiology as what we discussed. The fourth practical point is that use therapeutic drug level monitoring for indicated drugs. So as I was mentioning when about the complexity of PKPDs, it is for few drugs where the therapeutic range is very low, narrow. It is very important for us to hit the sweet spot to definitely understand, to avoid underdosing and to avoid overdosing and toxicity. So there are certain drugs for which therapeutic drug level monitorings are available widely commercially, where there is significant evidence to show that they are of narrow therapeutic potential. Yeah. Hello. So the majority of these three drugs are vancomycin, gentamicin, and voriconazole. So at least for these three, we should have a system in place to look at therapeutic drug level monitoring and then use these drugs for regular practice. The fifth or the last take back is that we need to use high dose in certain conditions other than the ICU what we discussed. So high dose is used in meningitis, high dose is used in endocarditis, it is used in bone and joint infections and in those with high MIC infections. And about this MICs, I'm sure the next speaker, Dr. Sumit, would be discussing at length. So certain aspect where the concentration at the site of infection is low, we need to keep in mind about this high dose. So to summarize, the clinical utilization of some of this information is challenging because these are complex systems studied using in vitro and animal models, and some of them using what we call as population pharmacokinetics. A linear relationship between clinical outcomes and these parameters are difficult to establish, meaning if you do this, you will get better outcome. It's sometimes difficult to establish, but they lay down mostly the basic best practice principles. They help us in our dose and dosing strategies. So it is one way of optimizing the antimicrobial use to ensure that you have highest efficacy, you have least toxicity, and you have less chance of developing resistance. So 4 key take back points from this discussion. One is that we need to understand the PKPD category of the antibiotic, which requires prolonged infusion, which requires single dose infusion, which can be managed by short infusion, which requires multiple dosing, which is lipophilic, which is hydrophilic, etc. So that is the first part. The second is that we need to identify the clinical situation with altered pharmacokinetics, where the doses has to be adjusted. So this is septic shock, multi-organ dysfunction, patient on renal replacement therapy, etc. You need to acknowledge the site of infection and body weight because the dose will vary accordingly. So the dose will vary in obese patients. It can vary in meningitis and bone infections. Knowing the MICs might help in borderline cases where you can actually use a high dose of the regular antibiotic instead of an alternative antibiotics in select cases. And the next speaker will be speaking much more about the MICs. Thank you.
Hello. Yeah, thank you for the talk, sir. It was a totally different way of looking at things because as physicians, we do use the antibiotics in and out. But then you're looking at a totally different scenario like patient with sepsis or MODS. I mean, then we do need to consider the way and the dose at which we are giving these drugs. I have a question for you, sir. Now, when we are saying a patient who is in the ICU and who's on multiple drugs,
Hello, I lost you in between. Can you repeat the question, please? The patient in the ICU? Hello? Hello, I lost you in between. Can you repeat the question?
yeah, my question is that when a patient is on multiple drugs and we're looking at estimating antibiotic dose or looking at a different way of delivering the drugs in terms of duration gap. So what happens to drug interactions? How does it affect the antibiotic efficacy?
So primarily the drug to drug interactions are important because we know that there is a propensity for either adding toxicity, there is a propensity for either reducing or increasing the dose based on how that affects the metabolism. One of the common examples of these are when you have rifampicin on board for any reason. The other most common area in ICUs when you have azoles, antifungals, especially voriconazole, when you have voriconazole on board. So that is again something with high interaction. So for any situation where we have polypharmacy, definitely we need to look at drug interaction profile. It alters the drug levels in terms of either increase or decrease. That will have an impact on either efficacy or toxicity. We know there are handful of antibiotic drugs which are known or notorious for drug interactions. So azoles, macrolide group, rifampicin group. So these three or four groups, whenever they are on, when we are macrolide, when you have quinolones, when you have azoles, definitely we should be on watch out for these drug interactions.
We will now proceed to our second session, interpreting cultures and antibiograms, where
from the stewardship point, I cannot answer that question. But as an ID physician, whenever we are getting consent, we will definitely. In the morning, we were discussing that meropenem has, especially if it is Acinetobacter. If we are giving meropenem as one day, maybe it will not work. You have to give extended infusion meropenem. Meropenem has to give us 3-hour infusion. Then only there is any chance of meropenem 2 hours. In scenarios, we will give. For example, if it is CRA, colistin resistant Acinetobacter, now the idea guideline is ampicillin sulfactam. So ampicillin sulfactam high dose has to be given as 4-hour extended infusion. So those kind of guidelines we use to follow. We are following.
Mentioned that you put a note in the file, and so what are the medical legal implications of especially when there is some non-compliance or something? How do you tackle those scenarios?
Yeah, so that's why I suggested to run through your legal department. We run recommendation form through our legal department, and that legal department, our legal department told completely fine to keep a recommendation form in the file because it is just a recommendation or suggestion. So the primary department need not follow that. Why there is a recommendation? That we need to clearly understand, because once there is a patient in the hospital, that patient is the responsibility of the primary treating doctor. But that patient is also the responsibility of the hospital. So from the hospital, it is a policy and process improvement. So something which helps the policy and process improvement can add on to the patient care.
Thank you for a wonderful presentation. I'd like to ask some questions and add on what he said that this is the job of the AMSP core team. When we go into prescription auditing, we always check whether the antibiotic was given as a extended infusion or not. So in our prescription audit form, we mentioned that if it's a time-dependent antimicrobial was it given over 3 hours or not, so that we check in our prescription audit form. When it comes to your question regarding medical legal aspect, when it comes to the prolonged or the extended infusions, if you can imagine, the concentration of the beta-lactam drug rising slowly, but what happens in the initial 4 hours when it does not cross the MIC. So in that case, you can give a loading dose for beta-lactam drugs in high concentration. By the time that falls, you have already started a second dose as extended infusion. So by the time that initial shot that has gone out the MIC that falls, you have already attained a particular concentration with the extended infusion. So if you're talking about the medical legal aspect, why did you give the drug slowly when the patient is sick? So in that case, you can give loading doses just to attain that particular concentration of the MIC, and then later on follow with the continuation dose. I think that's the more rational way of doing it. And also a question for you, sir. Other than colistin and tigecycline, what are the drugs that you recommend or you follow loading dose concept?
Our hospital, it is basically colistin, tigecycline, voriconazole, sometimes minocycline if it is if that is what the situation is. Then Caspo 70 mg loading dose and 50 mg.
So it is primarily antibiotic oriented or it is syndrome oriented?
Antibiotic oriented. Because it is a general stewardship recommendation, sir. So that is the other thing has to come from the physician.
Just to both of you, because for example, I have decided to give penicillin 6 hours late. My loading dose would be 4.5. So when should my second dose? Because as sir said, the MIC have to take care, correct? So when should be the second dose? Is it like after 6 hours or like after the loading dose, immediately I need to give the second dose?
No, after loading dose, you need to give as per schedule only. For example, your penicillin tazobactam 3.375 630 or 4.5 gamma. That is what we are practicing with. So the second dose will come after 8 hours.
8 hours.
Yeah.
But even if I given the extended hours, 3 hours in division, so beginning of the first hour, it will be taken as 6 hours later. I want to so our practice probably we may have to change. So just
the thing is that with DLP drugs, for example, if you're in the first shot in the patient, first drug, so you give a loading dose. Once it has reached a particular level, then you can maintain the trough levels by these continuous dosings. Okay, that is one thing. The other thing is that regarding the beta-lactam drugs, so there's one thing known as Bayesian dosing. Okay, Bayesian dosing means there are Bayesian dosing sort. Some are paid, some are free of cost. Certain websites are there. So in that case, you can add, you can put the creatinine clearance, the what is the MIC that you what dosing, you can say dosing criteria or dosing method that you're using, you will achieve the maximum target or percentage of target attainment. That means, like for example, if we say that if we want a maximum 100% of target attainment for treatment for beta-lactam drugs, so you can give even for the let's say 4.5 into 3, so that means 13.5 grams for the whole day. So you can even use 8 milligrams for the whole day if you go for a continuous infusion dosing. 24-hour dosing, not like in parts. You can use like 3 grams of loading doses and maybe 5 to 8 grams as a continuous dose that keeps on going through the whole day, not as extended infusion also. So you can use Bayesian dosing software. So overall your total consumption of the antimicrobial will reduce. That is one thing. The only problem is that since the continuous infusion, so it will be slightly difficult to manage the patient that way. Ambulation becomes a problem like that. But otherwise, you can reduce the total drug given to the patient by Bayesian dosing softwares. So the first dose can be given as loading dose, then you keep on or a extended infusion.
Fusion will be organism dependent, or
It will be site dependent also, organism dependent also, and drug dependent also, and of course the MIC also. Medium. Normally they are done by HPLC method. Normally pharmacology department does that. I have no practical experience with that.
Not much. We are doing for Oregon also, we are doing for Bangalore, we are doing for
Outsourcing.
Yeah, I don't like we are doing our yeah, everything is less than 1,000.
But again, that's very critical because at what time are you sending the sample? Like what trough levels have you attained? Once you attain the trough levels of the third or fourth dose, then you take the blood sample and send immediately as possible because there will be metabolism of the drug in the sample while you're sending it. So there are certain, I think
the sample has to be sent, like for example, if we are planning to send one after giving the third dose, then just prior to 30 minutes prior to the fourth dose, we will send the sample for assessing the. Thank you.
Time is over.
Yes.
Is there any calculation for the loaded dose in adults? You have satisfactorily diagnosed clinically the infection, whether it is the site or the severity, etc. But since they come loaded with comorbidities, do you wait to get their NFTs and renal profile, or how do you give the loading? Because even give the loading as early as possible is one of the good practices to contain the infections. Also considering the galloping clinical course the others have.
No, loading dose is not dependent on volume of distribution or creatinine levels or liver distribution. Loading dose has to be given. Because loading dose, the only aim of loading dose to maintain a threshold of drug in the serum. But all the PK/PD aspects will definitely come into place once we are thinking about the maintenance. So follow-up dose or the maintenance dose we will have to take up according to the clearances.
If you're giving a nephrotoxic drug, maybe then later on third, fourth dose, later on you might start monitoring the cat. But initially it's not required.
That sounds convincing. This is a point to be noted because you're going to encounter more and more situations where you have older patients, multiple morbidities, acute infections, probably accessing health support late in the day. Any other questions? Any other questions?
Dr. Deepu, there are some antibiotic stewardship programs where dispensing itself of the first dose is regulated. How feasible do you think that is in Indian scenario, especially where we have so many corporate hospitals with different antibiotic policies, different protocols?
Yeah, so the last slide I told you, the stewardship program, any process that is for the patient. So whatever you are told, that is coming under the umbrella of pre-authorization. For pre-authorization, the thing is that we need to have a very robust system. For example, at night somebody wants to start the antibiotic, and if there is a pre-authorization required to give that antibiotic, then the patient safety might be compromised. So if you cannot ensure that pre-authorization is going to happen within an hour, then I don't think that is actually feasible.
Because for the first dose or the first loading dose, many places take second dose, third dose onwards, you have to justify that continuation of the drug.
I agree. I think that would be more practical. So the rest of the questions, if I will address during that stage.
Before we say thank you to you, Dr. Deep, please permit me to make a few comments. What I would like to say is to just add something to your question of the threat of medical legal issues. Before we make, this is just for you as a thought. I understand you said that you will go review and make a note of recommendation or suggestion most politely in the T-sheet. And if it lands in non-compliance, how do you deal with it? Is there a possibility to be considered that have a communication, have a dialogue with the primary team, and whatever you conclude, put that as a solution or what you conclude as the best way out, because everybody has the same goal of getting your patients recovered. So that might, to a certain extent, help you to avoid these medical legal issues. And that's one of the suggestions which I could think of as a thought. Number two, alongside the bacterial resistance or alongside the microbial resistance, the bigger challenge for the stewardship program is the clinician resistance. And when both the things are combined, you can understand the magnitude of the challenge. So to get over that, what he was saying as your art of communicating with the primary team is better made when there is a good, knowledgeable awareness on part of the clinicians, which is what the CLE is probably designed for. Awareness, let it not remain at the level of cognition. Let it trickle down into practice. When I say practice, it's a day-to-day practice. And when I say day-to-day practice, it is every single patient you are dealing with. And if you are only tuned to blindly following the protocols, alert yourself. Protocols to be treated as guidelines. And the art of medicine lies in perfect customization for every patient. That's when you can justify every action of yours and the clinical decision making. So these are the things which you have to trickle down, and it should run in the clinician's kind of DNA. It's only then that we're really going to get. We all applaud the team and the multidisciplinary coordinated efforts of a group of people, admin, clinicians, and everybody concerned, including the nurse. I didn't think they saw the nurse in your team.
Infection control.
Okay, they come through that. Okay, so this team is what we all would like to applaud, agree. But let's not forget that every single clinician is a part of this team. Correct me if I'm wrong. Is a part of this team, because you're not just exercising your best acumen to decide on the drug, the dosage, the duration, the route, etc. It's also important that every clinician plays a role in education of the public. We're not going to leave it entirely to the stewardship program. Every patient we encounter, you have a set of relatives, you have a practitioner who has referred their case. Tertiary hospitals get this kind of a thing. It's our duty, every clinician, to educate that small segment of the public. That's when little drops of water will add up for the ocean. So please don't let it rest entirely on somebody to educate the public. I know there are very big challenges in the public setting where we have very little control over the counter prescriptions. Even criminals are getting given to the patients without being asked or questioned about it. So when that is a challenge, education of public is very, very important and a role to be played by every single clinician. Thank you very much for the thoughtful evaluation of people. We all of you will definitely echo with me when I say we really appreciate it. Thank you very much.
Quite an informative session. I thank the speaker and the chairperson. Now I request the chairperson to felicitate Dr. Deepu.
With an activity sheet. Thank you very much. Good job. I really liked all the subcommittees of this ADP stewardship, antimicrobial stewardship, and so on.
Now I request Dr. Ashwardhan Rao, the Professor of Gastroenterology, to felicitate the chairperson. Also, it's a great input to give you the session. Now I proceed to our fifth session of the day, which is treating multi-drug resistant infections. I am next esteemed speaker, Dr. Sunil Karan, Chairman, Head of the Department, and Consultant of Critical Care Medicine, Manipal Group of Hospitals. Hearty welcome to you, sir, and we're delighted to have you with us. I also welcome the chairperson for the session, Dr. Rupa Rani, who is the Professor and Head of the Department of Critical Care Department, and Dr. Shrikant, who is the Associate Professor, Department of General Medicine. Dr. Rupa Rani to kindly introduce Dr. Sunil Karan.
Good afternoon, everyone. My privilege and pleasure to introduce Dr. Sunil Karan. He is the Chairman and Head of the Department of Critical Care Medicine, Manipal Group of Hospitals. The pioneer in critical care medicine and neurocritical care in India, being the first batch of national board trainee in critical care medicine. He is one of the very few in our country to have 3 fellowships from 3 different continents, namely India, Australia, and New Zealand in critical care medicine. Sunil Karan is also senior faculty and examiner for national board training in critical care medicine and for fellowship program in critical care medicine under the aegis of Indian Society of Critical Care Medicine. Along with being an expert and one of the pioneers of the utility of point-of-care ultrasonography in ICU and usage of ECMO, Dr. Sunil Karan is the author of chapters in many national, international CCM textbooks with numerous research publications in national and international journals. The goal of AMS is to prevent multi-drug resistant infections, but we do encounter several multi-drug resistant infections in our ICUs. So we are very eager to know more about treating the multi-drug resistant infections. Over to you, Dr. Sunil.
Thank you. Thank you for the generous introduction. I think it was too long. I have no disclaimers to make except that I'm probably an odd man out, not being a microbiologist or not being an infectious disease expert, but of course, as a part of our work in critical care. Now, the problem of treating resistant infections is becoming definitely what we predicted 20 years ago when I was a student to now. There is a market change in the scenario that we used to see. So today, I think when people come from the community as a intensive care physician, we do not have the guts to start somebody on something very small. There was a time when we used the third generation cephalosporin and at best a BLBLI. In fact, when I trained overseas to, as we have already been alluded by the previous speaker, to get the carbapenem to be delivered to the ICU, it was a very long process, other than the first dose probably, but it was a very strictly regimented kind of approach that used to be followed. But I think if you look at the ground reality, gone are the days when we are receiving the right antibiotic at the right time. And of course, making sure that there are community-based side effects of doing this inappropriate or what I would even call it sometimes irrational, fear-based treatment of a critically ill patient does affect, it is something of a very tightrope walk, although it's difficult to do. The fact that antibiotic resistance is not only a problem of what we do, but it's also got to do what the environment does, what people in the community do, and also, of course, what the organism has a role to play. But it's this complex interplay between the different things that seem to be the cause for what we are facing today. Is left in the pipeline for us to use. And what we have been doing in the last decade or half a decade is like reinventing some of the old drugs, trying various sort of different kinds of combinations, and trying to see what we can achieve in terms of giving better care to our patients. Now, there are not only differences in, as I said, the 4 or 5 different factors which have a complex interplay, but there is also a role being done by different industries, agriculture, sericulture, where antibiotics are being used rampantly. So when we talk about giving a kind of a prophylactic role to how we reduce antibiotic resistance, or we bring about apt measures, it has to be a more holistic global role, as we are seeing with the Government of India initiative in the Chennai Declaration. Now, there are also regional differences. The common or the risk factor for developing what we call as antibiotic resistance seems to be a little different in different parts of the world. Of course, in the developing world, where especially India is called the capital of antibiotic resistance, we do find that abuse is one of them. The availability of over-the-counter drugs, the use of these in other industries such as sericulture and farming, and of course poor sanitation, which actually helps in spread of these organisms, seems to be one of the key factors. As compared to the more developed world, where we see that spread from the healthcare facility, inter-nation transport or inter-border transgression of people, migration of people, and of course to a certain extent antibiotic misuse seems to be some of the lead roles. So if you start looking at different areas of the world, you have to probably address the specific causes or specific problems that are there or risk factors which are there in that given area. So the mechanisms for antibiotic resistance, I'm sure you've all already been spoken to. Most importantly, the entry of the antibiotic is stopped, or the antibiotic that enters the bacteria is facilitated to be thrown out early or hastens the excretion, or by actually hampering its binding and causing sort of modification or changes in the structure of the binding site. All these are certain things that help, or that sort of general principles in which the antibiotics develop resistance. Now, the problem is not restricted to India; it is global. As we know, about 60% of it starts from about 6% and goes to other areas, about 60 to 70% of isolates, where we actually see XDR organisms. And unfortunately, we have the dubious distinction of being called the antibiotic resistant capital of the world. How much of it we don't want to be called so, but we have to look at the harsh realities of it and do understand that we do have a problem. Now, if you look at the incidence of Klebsiella, which was initially HDR, more progressing towards PDR now, there was no incidence of colistin resistance in the last 2 years. We are reporting patients of with CRE or with the carbapenem resistant Klebsiella becoming colistin resistant. We are seeing a creep in the value of MIC for various gram-positive organisms. So all this is going to impact what we do at the bedside. So that's why it's very important to understand that we have to take measures to actually prevent the problem. We have to ensure that we hit the fine balance of what we call as personalizing care, or as Madam already mentioned, individualizing care at the bedside and applying the guideline at the bedside in terms of ensuring that there is good care given to the patient, and at the same time we also ensure that there is our community responsibilities are also done. Now, for all practical purposes, the discussion will largely be rolled into the three organisms that are the biggest contributors of problem, and the WHO actually did put out these three organisms, the gram-negative side, as the priority organisms or the high priority organisms, namely carbapenem-resistant Enterobacteriaceae Klebsiella, carbapenem-resistant Pseudomonas. It is not so much of a problem in this part of the world, but we do see it in certain areas of the country as well. And of course, carbapenem-resistant Acinetobacter baumannii. So Acinetobacter and Klebsiella, these are the two sort of, should I say, points that we are going to talk about, of the king and the queen of our chessboard for today's discussion. And on the gram-positive side, not yet so much of a problem, but as I said, we are beginning to see more and more patients coming with community-acquired MRSA, patients coming with community-acquired VRE. The MRSA is now becoming VISA, which is vancomycin intermediate sensitive, and also we are one or two stray cases of vancomycin resistant or what's the vancomycin resistant staph aureus which we are beginning to see. So I'll skip this slide. I'm sure you have seen how the mechanism of how the resistant mechanisms is spread. Now, coming to specific examples, beta-lactam resistance are seen because of different types of beta-lactamases, carbapenem resistance because of carbapenemase producing organisms, also because of certain mutations that take place, and efflux pump regulation where the carbapenem is actually pumped out of the gram-negative bacteria. And there are other specific mechanisms related to specific antibiotic classes like the mutation to DNA. Such as the mutation to the DNA gyrase gene, which is the site where the fluoroquinolones act, upregulation and upregulation of the efflux response that you see in digicycline, and a whole lot of other mechanisms which are specific. Now, this is the broad clinical classification, which may have a certain amount of clinical bearing in the ICU, where the beta-lactam enzymes are divided as per the AMBER classification, class A, B, C, D. Now, particular of relevance to us is that 10, and we do see OXA 48 and OXA 23 as well. We do see NDMs. So these are some of the things which do have a bearing for our KPC1, 2. These are all the different classifications. And as you see, there are each of the gene has a specific antibiotic resistance that it plays. Now, this is important to know a few of these basic things because our therapies are now more and more based on looking at what is the genetic display that this bacteria shows. Because based on that genomic sequence, we are able to specifically choose the given organism. Now, as we go into the future, we have to look at developing specific genomic methods of early identification of these bacteria, so that we actually don't have to blast antibiotics when the patient comes in. Because if we can have a much faster time or a turnover time to get these antibiotics or get the organism with what kind of genetic makeup they have and what is the resistance pattern, then it will be much easier for us to start therapy earlier in these patients. Now, coming to a broad therapeutic approach to gram-negative infections, this is going to be just a broad prescription or a broad guideline, because you have to have a good idea of your local flora and what your resistant and common organism pattern. Now, what we say in this part of the world or in this particular venue may not hold good for our hospital, which works in a second-tier city or in a tertiary level center, which is much larger, or in a primary health care center. So it's very important to look at your data, keep scrutinizing your data every 6 months, and keep changing your empiric policies accordingly, and also look at how you can actually manage patients. Now, gone are the days when we talk about monotherapies for many of the common bacteria that I spoke to you. But still, 3 high priority organisms for gram-negative, because most of the time you do see that they are HDR to VRPDR. So most recommendations with very little strength of evidence in literature do recommend dual therapy, triple therapy, and sometimes you don't have anything which works. So you just sort of go based on your gut feeling or based on some sort of scientific rationale, but not based on RCT. So I think these are all the problems that we face when we treat these patients on the ground. So what is going to be given here is only going to be a guide. It may not be necessarily that what we're going to apply for every other patient on the bedside, and many times, as Madam mentioned, it is important to have a very close association or discussing, to be talking terms with your IDT, with your clinical microbiology, and it's very important that you actually do. So we have actually embarked on, we do have an AMR, a antibiotic stewardship program, but also we have embarked on a situation where every once a week we actually have an ID round which takes place, so that there are certain questions that the ID does ask us, or the clinical microbiologist does ask us to say why, and we really need to give a strong justification of why certain bacteria be. I do have a confession to make in that when we started this stewardship program, I'm sure Dr. Radha was also there when we started this. We actually had excluded transplant, ICU, and few other sort of key areas. But I think in the last 1 year, we have actually said that we don't want to be not excluded in this because it's very important that, as we know, that the breeding ground for these resistance are going to be ICU. So now, even in the ICU to actually start or continue a carbapenem beyond a certain time, we actually need to get the approval. So bottom line of this slide is that it is very important to understand the local flora. What is the empirical choice that you're going to make for your category 1, 2, 3 patients? Is community acquired or somebody who has been taken comes back to you with sepsis? Accordingly, you need to have your protocols ready. Now, this is a broad guideline, which is probably on how we talk about. So again, it is stolen from a review article, I will admit, but there are certain important things that we need to understand in terms of how to approach it. Now, you can have your own approach, but this is just a broad outline there. Two things that I want to emphasize is that we are talking about carbapenem resistant bugs here, and the common problem that we face is Acinetobacter and Klebsiella. And if we have a carbapenem resistant, then we do look at the genomic sequencing and see if it belongs to KPC oxide. And based on that, the use of centenary avibactam which is now available in the country for the last 3-4 years, and probably I would even say misused or abused in our country or in our part of the world. But this is one thing that we use with Astronam, provided we do know that it is sensitive, or if what we call as the synergy test comes positive, where we actually look at this combination. Now, many times we find that as individual, the drugs may not be effective, but when we use it as a combination, it may be helpful. So when somebody or a particular sample comes positive, blood, whatever, generally blood, but we try to do it in other fluid samples as well. If we find that the patient has isolated Klebsiella, we go through this gene sequencing and see what we call the CARBAR test and see what is the predominant gene that is there. Now, if it's only OXA48, then we can only use the ceftazidime avibactam. But if it is the MDL or NDM, we actually use the ceftazidime avibactam in combination with Astronam, provided the new synergy test comes positive. All these tests again, a very similar kind of pattern where you could use ceftazidime avibactam in isolation. Initially, the data was not strong for its use, but in the last 2 years and a half or 2, we have enough clinical data to support the use of. Actually, when we started off using ceftazidime avibactam, it was not recommended fully for Pseudomonas, but now we are able to use it for that as well. For Acinetobacter, I think we know a little better about it. Of course, a combination of, as mentioned, using anti-sulfactam is one way. We use a combination of carbapenem with cholesterol. But for chest infections or VAPs, there is good data to use colistin only as a monotherapy. So we have there are 2 RCTs which have shown that using colistin as a monotherapy for VAP is as good as using a combination. So if they can avoid using a carbapenem, it's better to do so. We have moved from using only for chest, I'm talking only for VAP, but for any other, CORT or CRBSI, if you have Acinetobacter, then you keep using colistin with carbapenem or antisulbactam, high dose ampicillin with sulbactam. So this is the broad kind of outline that we would use for our 3 star players in the ice, which is Klebsiella, Acinetobacter, and Pseudomonas. Now, coming to some of the, just a broad review of the common infections that we see, bloodstream infections. Now, if it is because of catheter, we add the additional eclampsia because of certain morbidities. Now, there is definitely associated mortality and morbidity, which is much higher when we have patients who come with XPR. Now, what we call attributable mortality seems to be about 70%. Now, there was a time when people believed that hospital-acquired infections may not cause an increase in mortality, but only may cause an increase in morbidity. Now, we need to understand that when somebody comes with a critical illness or whatever, maybe trauma, it may be dengue, severe dengue, anything it is, every disease has its own mortality. Now, these additional factors may not grossly change the mortality on a crude mortality when we see. But it's very important to look at what we call as attributable mortality. So it's not enough to pat ourselves in the back and say, okay, my overall mortality for this given severity of illness of what we call as an SMR or Apache doesn't change because of a nosocomial. But there are a lot of secondary outcomes which change. And when you look at what we call as attributable mortality, you do find that there is a marked increase of over 60 to 70%. So some of the risk factors are most of our chronic problems, and importantly, what we need is previous antibiotic use. And if there's already been Klebsiella bacteremia, these are some risk factors for a higher risk of having a recurrent infection of Klebsiella. And different combination, but at the moment, data is for using high dose meropenem or any other carbapenem, but most of our meropenem just, I think, just based on the fact that it's just been utilized so much and there's enough data for it in combination with anything else, like some other any other adjuvant which we can use, phosphomycin. All these again, I'm saying not based on strong RCTs. All these are based on cohorts, maybe small RCTs, maybe data which is extracted from case series, etc. So before after study. So whatever I'm going to tell you is that that's why I said it's a very blanket, broad spectrum sort of guideline. It's not going to be probably going to be avian. So then, in fact, some of these combinations that we have been using, phosphomycin, meropenem, you find that the MIC goes above 16. That's a questionable role of using it, using meropenem or a carbapenem in the form of meropenem with phosphomycin. So when we talk about choosing a combination in your given center, it is also important to see which of the MIC, which has the lowest MIC, and when you pick up that carbapenem with the combination of something else. Sometimes 2 is not enough, we go for 3 combinations. So, it's like, it's something that you have to look at your bedside and look at your data and decide. But on the whole, look at data in the last 3, 4, 5 years, probably, colistin with meropenem seems to be the most accepted combination, but that is also going away gradually. Or you could use any other carbapenem with phosphomycin or phosphomycin with tigecycline, high dose tigecycline, or double penems with phosphomycin. So these are all kind of different combinations that I'm giving. But again, don't hold me or don't beat me up for being so vague and so this thing, because that is unfortunately the situation that we have come to. So coming to hospital-acquired infection, as not much of a change for the Klebsiella or Acinetobacter. I already told you, you could use single dose. You could use only colistin as a single agent, or you could use antisulbactam. If it is sensitive to cephalosporin sulbactam, then we can use cephalosporin sulbactam with high dose sulbactam. That's another combination that can be used. But on the whole, the recent recommendation is to use ampicillin sulbactam or colistin alone if it is Acinetobacter. And of course, if you have Klebsiella, I think you're left with very, very limited choice. community angle, somebody who comes from the community with bacteremia, there is a catch. If they are even if they have bacteremia from an ESBL producing organism, there is some clinical data to say that use of carbapenems in this scenario probably helps in early organ failure reversal, shorter ICU stay. Now, as an ID physician or as a microbiologist, it is a questionable thing to say, why are you going? So what we go by is to see that if somebody has shock with bacteremia suspected to be gram-negative, because most of our community, more than 60% of our community gram-negatives are ESBL producers, we obviously start them with carbapenems and then look at scaling down once shock resolves and once organ reversal happens. At least till shock resolves. So even if you start somebody very early on, on one of the broad spectrum cover, make sure that you have appropriate de-escalation at the right time. The same thing holds good for UTIs as well. There seems to be a slightly higher rate of recurrence, longer ICU stays, longer shock reversal when we actually treat UTI with ESBL producing organisms with only BL-BLA combinations. And that is why the tendency now is to or the guideline recommendation in critical care circles is to use carbapenem and then de-escalate once shock reversal happens. So this is one area where there could be a difference of opinion that we may have with our ID counterparts or with our clinical microbiologists. Of course, if the organism is resistant to carbapenem, then I think we are left with very, very little choice. Now, a word about colistin and polymixing. I think we had discussed this in one of our previous lectures together. I think there is more and more data emerging for the use of polymixing in place of colistin whenever you're going to use colistin, either in combination with carbapenem or without. But you need to understand that polymixing is not secreted in the urine or not excreted in the urine. So the role for polymixing would be to treat bacteremia, would be to treat soft tissue infections, or for treating a chest infection or a VAP with carbapenem resistant organisms with or without any other combination that you want to use. So there was a thought when colistin started to be used about a decade ago or about 5 or 8 years ago that this colistin that we are using today probably causes lesser nephrotoxicity, which is true, but it is not uncommon to actually see nephrotoxicity or AKI happening because of the use of colistin, particularly in critical care circles, because the kidney is already badgered with a whole lot of other sort of injurious events. So when possible, we are trying to use more and more polymixing these days, unless we are suspecting urosepsis where colistin is still the preferred choice. So this is one thing that I wanted to say. And one more thing that we need to understand is when patients do have a creatinine clearance of less than 50, it's very important to dose modify polymixing as well. But dose modification doesn't hold good for the bolus dose, as Sir had already mentioned. It holds good for the subsequent doses that we are going to use. Now, certain other scenarios that we see in the ICU is when we talk about resistant infections. Two categories, if I may say, one is ESBL producing organisms and one is carbapenem resistant organisms. Is the intra-abdominal infections. Here again, there is if somebody does come very, very sick from an intra-abdominal infection, primarily from the community with severe shock, suspected to be an ESBL producer, I think our tendency would be to start them on carbapenem. Because again, we wait for shock reversal, we wait for the source control to be done, and then once the big shock reversal has happened, we can start scaling back to a VLPLI combination. Alternatively, to use carbapenem sparing strategies, there is data to some good, strong RCTs to support the use of ceftazidime avibactam in place of carbapenem, which is non-inferior to carbapenem alone. But this again is, as I said, more relevant to community-based, particularly in intra-abdominal sepsis, which has happened with somebody who is hospitalized or we suspect a carbapenem resistant organism like CRE or Antimicrobial or what we would commonly call as CRAB, then I think your option is again very, very limited. Now it's important to understand that when we use ceftazidime avibactam, we have to use metronidazole if we are talking about needing anaerobic cover to the intra-abdominal infections, because unlike carbapenem, there is not very broad spectrum anaerobic cover with the use of the VLPLI combinations. And I'm talking about particularly the ceftazidime avibactam, whereas the piperacillin avibactam does have a reasonable amount of anaerobic carbon. The story today, as as we have seen in the last 5 years, or the story that's unfolded in front of us, is we have gone back to some of our older medications or our older antibiotics. Started off with colistin, then we brought in polymyxin. There is some revisiting being done for some of the aminoglycosides. If you look at some of the newer, recent isolates, you do find that they are sensitive to amic acid, or amic acid, gentamicin. Probably they are using them less frequently. So in that kind of a scenario, we are looking at reusing some of these older antibiotics, and of course higher doses of the existing antibiotics. As I said, one combination which was being tried and experimented on the clinical ground is double dose of 2 carbapenems with fosfomycin, etc. When we talk about PDR Klebsiella, but all this is based on very limited data. Next slide. We spoke about the adverse effects. I think colistin, you all know, neurotoxicity, nephrotoxicity. Fosfomycin, very important to understand that it causes a lot of tubular dysfunction and hypokalemia, hypomagnesemia, and hypernatremia. Particularly the doses that we use for treating CRE, we actually see a lot of hypernatremia. Very common. We actually, when people are on fosfomycin, you see by about 72 hours, the sodium dips from 140 to 155, 156. So this is a huge problem that we face when we use fosfomycin, and it does have good data to support for its role. Definitely in UTI, no doubt about it, because of the extent of excretion of this molecule into the urine, and in other forms of gram-negative sepsis such as GI and bacteremias as well. Some doubtful role for VAP as well in combination with other things. Tigecycline has been tried again in much higher doses. Standard recommendation is for intra-abdominal infections, soft tissue infections. VAP, controversial role. There is a couple of studies which have shown a higher mortality. Not sure the exact reason for why there was higher mortality with tigecycline, but there is a black label sort of warning kept that you would not be using it for VAP. But desperate situations, we have used it, I will admit, as a combination with certain other drugs. And important thing here to understand is that this is a bacteriostatic drug. The newer treatment options, all of you are familiar with ceftazidime avibactam, or rather, the household term today is Zervisepta. I just finished my DNB exams. Students start off saying Zervisepta, then I have to say, no, you are not talking in company seminar, we're actually giving a DNB exam. So it's ceftazidime avibactam, and it's a relatively novel combination. But again, seems to be going, there is resistance being reported gradually, and as a monotherapy in NDM, it is generally not useful. When we use it with Stewardship, if the synergy test comes positive, then you can probably consider it as a thing. But for OXA48, it has good efficacy up to 85 to 90% clearance of the infection. The other in the pipeline is meropenem with vaporactam. Again, a combination of with one of the newer beta-lactamases, ceftazolone with tazobactam. Here, one thing is that this has a slightly greater pseudomonas cover than the previous one that I mentioned, but again, very poor anaerobic cover. And imipenem with relebactam is another one which is in the pipeline. Iracycline, which is being, which is a tetracycline, which is newer tetracycline, which seems to have about 85% cure rate, particularly. And even good intra-abdominal infection, complicated treatment for intra-abdominal infection as well, which is non-inferior to one of the carbapenems. Plasmomycin, another novel aminoglycoside, ceftioropol, all these are newer things in the pipeline, and a whole lot of things. I will leave it to you to read up from this thing. And now there are carbapenems being looked at with newer generation, what we call as newer generation beta-lactamase inhibitors, like zidovactam, which is a diazobicyclopten, which is a little more efficacious and a much broader spectrum of beta-lactamase inhibitors. So until now, first generation was not as broad, but this seems to be a slightly broader one. And coming to the less of a concern in our setting, but definitely becoming a new problem, is gram-positive infection. Here again, the top 3 winners would be MRSA, Enterococcus faecium, and penicillin-resistant strep pneumonia. This probably still not so much of a problem. Around 2 to 5% of our isolates are only having this problem, but I'm sure it's going to get worse with time. Here the concepts of concern for us on the ground. All of us know that MRSA standard treatment vancomycin, and now we have moved to teicoplanin, because of its lesser renotoxicity data to show that it is equal or non-inferior to vancomycin in many clinical settings. A lot of RCTs and meta-analysis which show that it is equal and equally efficacious. People have used linezolid quite rampantly for convenience, for cheaper, less complication, quote unquote. This again, I would not agree completely that it is having less complications, but for all these various reasons. And we are actually seeing that there is a creep of the MIC from the 0.5 to the 1 to 2, and that's a concern with vancomycin. The same thing is happening on the with Enterococcus as well. Though we still have very less extent of very less incidence of VRE at the moment, I'm sure we are going to see more of it as we go further. So that moving from one in the creep, moving on to becoming more incidence of VSA and VRSA, we are likely to see. The treatment for this is going to be, and anybody who has a vancomycin MIC of 2, though the lab does report it as sensitive based on the guidelines, I think the recommendation is to start these people on an alternative, either on linezolid or on daptomycin. Obviously, when we talk about linezolid, during it is daptomycin is the natural option left for us today. Other drugs are there, but not yet available in the country. The other newer antibiotics in the pipeline for treating this group of organisms is ceftaroline. It has just come, as you all know, ceftabiprole, newer oxazolidones, and omadacycline, which is one of the newer tetracycline. Mechanisms of resistance from gram-positive, very similar to gram-negative. Here, it is more the outer cell wall, cell membrane, cell wall, which is there, and therefore, binding, efflux, plasmid mediated, alteration of the DNA, all these mechanisms still hold good. And the long-term view is, or things that we are looking at differently is, one is of course looking at newer types of antibiotics or newer modalities of antibiotics, such as the ordinoharbins, which is a new class of antibiotics coming out from one of the bacteria, which is having a very complex name. You can read it up. But phages, which can destroy the pathogenic bacteria, is what is being looked at. But we still don't know how well clinically relevant it will become, because there is a possibility that we also wipe out the normal commensals, which are useful, quote unquote, because useful bacteria. So that's something in the pipeline and maybe an answer to decrease our antibiotics resistance. So some of the considerations for the future, or for what I would call as the bleak future for us for now, is to improve our diagnostic techniques. It is on the pipeline. We've seen quite a bit of advances in the recent past, but the problem with the genomic techniques is that it is too sensitive. You send a bar, you will get 6 organisms in that, and you don't know what to treat, what not to treat. So, but for certain sterile samples, like maybe CSF or pleural fluid, that seems to be a little more sensitive or a little more specific. But we send a dirty sample like Pearl or anything else, you find that you get a whole lot of. So improving the specificity is one problem that we need to face. Of course, faster turnover times, and this genomics technique should help us to get a resistance pattern, not only identify the organism, but also give us the resistance pattern is the future, so that we don't have to use the antibiotics left, right, and center. Looking at reduction of the use of antibiotics in other spheres of industries, newer antimicrobials, I don't know, we are 10, 15, 20 years away. We're only sort of rejigging the world ambassador cover and trying to get Mercedes out of it, and that's what's been happening in the last 10 years. And of course, we are talking about antibiotic stewardship program. Again, how disciplined are we going to be? I should admit that in the ICU, many times we are not so disciplined, at least in the first 48 hours. And so these are all some of the things that we have to look at it. Most importantly, I think to look at a national level program. Now, it's not, we have made a start, but we have not taken it forward. So we need to have national data, national registry, and we can't be looking at state level, local. This is one part of it, but I think all this going on to a national registry is extremely important. Only then I think we'll have a more holistic answer to some of our problems. So that is in short what I would say, and thank you very much for your patience. I'm sorry, it must have been a very broad-based class, but unfortunately, that's how we treat our patients as well when they come with these organisms. Very broad-based, half-hearted covers.
So, I just wanted to know, you showed a lot of carbapenem sparing drugs, sir. So as an intensivist, I would like to know your experience on using carbapenem sparing, because when we yesterday from a PSPL, every patient is important. We have more experience with carbapenem. So really, does the use of carbapenem sparing drugs reduce resistance to carbapenem? First question. And if you're doing that, your experience.
To be telling you the very honest truth, I think we are using carbapenem sparing drugs more because of the fact that we don't have anything else to use. But honestly, I will be a little reluctant to use ceftazidime avibactam to spare carbapenem because I need it for my Klebsiella. So I think what studies are done in Europe or in the US may not be completely applicable here. I don't have a direct answer to your question because, as I said, in all our circumstances, we have used carbapenem sparing drugs only because we didn't have a choice. Other than probably now looking at Antimicrobial, in the last 6-8 months, we have started using it as a monotherapy for cholesterol for Antimicrobial VAP. And I have not had data, but whatever patients we have started have come out well. But you can also debate that there is some literature to say that Antimicrobial VAP is not as harmful as other VAPs. So, people don't die. So, in fact, there was one school of thought at one point that should even treat these VAPs, especially when we talk about Antimicrobial. Somebody grows it. If there is no worsening oxygenation, if there is no shock, we don't treat those VAPs, just leave it alone. Therefore, the only experience I can tell you is that we have stopped using carbapenem in this setting. Do you have anything to add to that?
I think in an intensive case, I think it really doesn't matter whether you have to spare carbapenem. The focus is on sparing the life of the patient. So from an antimicrobial stewardship perspective, yes, carbapenem sparing for a broader goal is acceptable. But first goal, save the life. Carbapenem is an essential weed in it. So beyond ICU, patient goes out of the ICU, you start de-escalating. Only then probably the carbapenem sparing strategies come into picture, not on the patient per se.
Talking about the synergy between Cefta-AB and Astronam, there are two things. One is synergy when we do either test or an Astronam test. Synergy is one thing, but synergy does not mean that will get down the MIC of Cefta-AB to within the susceptible breakpoint zone. So ideally, we should do the MIC testing in the presence of Astronam and in the absence of Astronam. So if the addition of Astronam is able to bring down the MIC from, let's say, 126, 128 to, let's say, 32, that is not going to be effective. That shows synergy, but that does not bring it down to the susceptibility breakpoint range. But at the same time, if it is able to get down to as low as maybe 16 or maybe 8, that's the time that we can say, okay, now it might be effective. So synergy does not necessarily mean effectiveness.
But I think only if it comes down to that extent. They say,
yes. Yeah. And one more thing is regarding that, whenever we do the cultures, we always try to gauge or assess whether it's a low inoculum infection or a high inoculum infection. For low inoculum infection, we would probably go in for a carbapenem sparing therapy with piptazole, maybe a glycoside. And when we have higher inoculum infections, then maybe we can follow the guidelines for the medical trial, maybe go through carbapenems. So for broad guidelines, that's what we do. Somebody comes with shock, and most of them actually do come with shock. We start carbapenem and then kind of de-escalate now. In that de-escalate is not going up in the community. Sir, how often do you use nebulized antimicrobials in your practice? We have not used it. Like antibiotic, again, I know there are a few studies which have shown, but that is not in spite of other antibiotics. Most of them have been, have been very sick. You would not have the. Even with the VAP for with the MDR. Yeah, we use only this. Yeah. Maybe as he said, in a scenario where somebody has Acinetobacter VAP stable, you don't want to treat, family wants to take out use it. But again, we don't know its effect on spreading antibiotic resistance. So ideally systemic plus nebulized antimicrobials. But not large enough trials for us to add another antibiotic, and we need to understand that we're talking about doubling the cost. It's almost the full you don't have a specific preparation of Acinetobacter, of listing which you can keep in because it's actually same cost. You are adding something which is gassing in it. Many of our ICUs do not have that ultrasonic in the ventilator. A lot of it just remains in the ventilator circuit. It's not enough to just gas it into that. You actually really need to have a good electronic ultrasonic
Spoke about genomics. Like a lot of companies already have this multiplex PCRs which are already available. But as of now, do we have data comparing these multiplex PCRs or the test which you mentioned with the rapid turnaround time comparison with the gold standard?
It's not big. That's why we can't prescribe it as it. Anecdotally also, desperate situation, you send something, you get 5 organisms. You don't know which one. Definitely 2 culprits will be Acinetobacter and Klebsiella. Then you are left staring at what to treat.
Most of the time that the carbapenem and metronidazole combination to be avoided.
Carbapenem, you don't have to give metronidazole.
Carbapenem plus metronidazole.
No, if you are giving carbapenem, you don't have to give.
Setting up.
It was very informative and excellent talk about treating multi-drug resistant infection. Still, I think as the physicians and intensivists, we should balance between taking the sicker patients with higher antibiotics and preventing the multi-drug resistance infection. Yes, yes. Thank you so much.
Thank you, Dr. Sunil for an excellent section. We request Dr. Radha to kindly felicitate Dr. Sunil. Along with the chair control. We request Dr. Radha to kindly felicitate the chairman.
Thank you, Dr. Ruparani and Dr. Srikanth, for sharing the session. We now shall wait for lunch for 30 minutes and return to some exciting sessions that are remaining. Please head to the basement -1 for the lunch. Please join us for lunch. Opposite to VIP. Thank you. -1. Yes. Thank you. Thank you.
Sharing the panel is not there. Panel is not. It's rather on one. I'll just put it on this now.
Will we get time for panel discussion? Will we get time for panel discussion?
So right, what time do you have to leave?
I will leave by 4 o'clock.
Before that, we should be able to finish.
You'll miss my concluding remarks. Yeah. I was just wondering, it is 4 to 4 then.
No, so actually, that quiz will happen later and we'll finish up everything else.
Remarks and thanks before the quiz. And whoever wants to stay back for the quiz, stay back.
Okay. Then I will wait.
What time is your flight, sir?
Flight is at 8 only, but I don't want to.
Cut it too close. Right, sir.
The traffic is going to be hard. It's a Saturday. Saturday, Bangalore traffic. If it was Cochin, I would have said go by, 6:30. Doesn't matter. Hey, Michael.
Yeah.
Yeah. Michael? Oh.
All the presentations are going good.
Yes, and it's come out really well this year.
Yeah.
First, I would like to call upon stage our panelists, Dr. Sumit Rai, HOD AIMS Mangalgiri. Next, Dr. Pradeep GCM. Dr. Pradeep is a consultant neonatologist and head of neonatology at Ramaiah Medical Hospital, Bangalore. 18 years of professional experience in neonatology and DM neonatology from PGI Chandigarh. Numerous publications in both national and international journals. Dr. Pradeep is a consultant neonatologist and head at Ramaiah Memorial Hospital, Bangalore. He has 18 years of experience. 18 years of experience. He completed his GM from PGI Chandigarh. He has numerous research publications in national and international journals. He received the Dr. Anke Gowda Award for Best Scientific Paper presented at KP South Zone Conference and secured a gold medal at Rajiv Gandhi University for highest marks in his DCH exam. Invite on stage Dr. Sumit Rai, HOD Microbiology, AIMS Mangalgiri, Dr. Pradeep GCM, then Dr. Deepa Satyapalan, and Dr. Bharat Chapria. Dr. Bharat is Assistant Professor and Consultant, Department of Pulmonary and Critical Care Medicine at Ramaiah Memorial Hospital and Medical College. Completed his training in PGI Chandigarh. In both, he has done his MD, PGI Chandigarh, and his DM in Pulmonary and Critical Care and Sleep Medicine, also from PGI Chandigarh. His areas of interest include and interventional pulmonology. So my first questions are directed to Dr. Pradeep. How do we suspect hospital-acquired infections in neonates? What is the role of cultures, Dr. Sumit, in this? And since the culture positivity rate is low and no proper antibiogram or antibiotic sensitivity data is available, how will you discipline the empiric therapy? And are there any ways in which we can improve this culture positivity?
Dr. Nagesh Kumar Chasti, Associate Professor, Department of General Medicine, and Dr. Sandeep T, Associate Professor, Department of Microbiology. I request Dr. Nagesh to kindly introduce Dr. Vinay.
Back all the delegates and students for the fifth session, first noon session. Welcome Dr. Vinay, he head of infectious diseases division, Apollo Hospital. He is infectious disease physician with postgraduate training in internal medicine from PGH Chandigarh, with post MD fellowship in infectious diseases from Apollo Hospital, Chennai, to recognized by NBE. He has been trained by most recognized and respected infectious diseases physicians in India and has ample knowledge and expertise in handling complicated infectious diseases, including TB, HIV, joint related infections, and fever of PO and pregnancy related infections, and simple and undifferentiated fever and seasonal fevers. And he is also has been trained in travel medicine and vaccinology. So, welcome you and just to start the speech.
Thank you, sir. Thank you for the kind introduction. First and foremost, thank you for all of you at Ramaiah for having me here. Also, thank you for all of you for coming back post lunch and then sitting here. My job of discussing this topic has been made half easy by Dr. Sunil and Dr. Riku. I think whatever they have discussed, you'll see most of the slides repeating the same, though I'm not well into much detail. But Dr. Riku has made it a bit tough for me also. So the reason that he showed you how IMTL Antimicrobial Stewardship program would exist. So in a teaching institute, good effort, of course. I mean, they are a 1,200 bedded hospital. And despite that, I think whatever they have achieved is quite commendable. But I work in a corporate setup, and Dr. Sunil would agree with me. So things are a different cup of tea. It's far more tougher to implement these. So when I discuss and when I bring about the topic of tools to combat antimicrobial resistance, so I'll not be looking at much theoretical option. I'll talk to you about what we have now and what best of these tools we can make use of to bring about some sanity in a bad world of misuse of antibiotics. So I have no conclusion. Why are we discussing? Why do we need such programs? Why do we need such discussion? So for any of you who are Game of Thrones fan, everybody keeps scaring each other saying winter is coming. I believe scaring people by saying antibiotic apocalypse is coming. We are short of antibiotics, truly, and whatever antibiotics we have seem to be getting exhausted and exhausted quite fast. So for that reason, I think we're staring at something where very simple infections could kill us all if at all we don't preserve and use these antibiotics or any antimicrobial for that matter in a proper way. So why is it a problem? So if you look at numbers, not merely thinking about it, look at numbers. So at this current day and age, diseases caused by antimicrobial resistance kill nearly 1.2 million people a year. That's a huge number. Bulk of which is contributed by South Asia, and if you break down the numbers, bulk of them come from the Indian subcontinent. So the antimicrobial resistance is increasing, and it is estimated, predicted that by the year 2050, you'll have 10 million deaths, which will be one of the leading killer of men and women. And 10 million people dying every year because the antibiotics don't work very much in that situation. It's pretty scary. But the worst things yet to come are, having known that more people may die because of antimicrobial resistance, we still are not matching it in terms of number of antibiotics that are being produced, in terms of the research money that is being poured into antibiotics. If you look at it, the amount invested is very meager. So very less, the antibiotic pipeline is fast dwindling. So this is that we have very few antibiotics left with, and whatever it is, we have to preserve and then use them in a justifiable manner. Because the resistance rates for antibiotic in an enzymatic way or a non-enzymatic way is increasing. It is progressive. And India, as usual, is a major contributor to this antibiotic resistance. So why does this occur? One of the major reasons why this occurs, the resistance rates increase. Introduced shortly, the resistance also set in. So that's a rule rather than an exception. So that is one half of the story. If you look at the right side, this is what we've been discussing over and over. So that somebody develops an infection, may not need antibiotic or may need antibiotic for a long duration was given. So there is a higher tendency to form drug resistance. So then he went home, gave the drug resistant pathogen by interaction with his family members, or in the hospital, courtesy us, the healthcare workers, not following proper infection control practices, it spread to other patients also. This is, like I said, one half of the story. But what we don't realize is the major chunk of antibiotic consumption is not by us, it's by the animals, not by choice, of course. So 70% of antibiotic consumption all over the world is by animals, mainly in the animal husbandry industry, to keep them fit, smart, and then ready for meat. Not just meat consumers, even vegetarians are at risk of consuming more and more antibiotics in an indirect way. How? All the excreta that the animals dump, it goes to all the fields where the vegetables are grown. So how much of a red, green, and beautiful the vegetables might look, we are more often than not consuming antibiotics in an indirect way. So it is not surprising. I know for us clinicians, when we see a patient comes from the community, not from any other hospital, comes from a community, comes very sick, day one cultures already show a drug-resistant pathogen. So this is because we are rather consuming antibiotics in direct or indirect way. So this is the gist of it, that whatever antibiotics we are already consuming it. So every antibiotic we are developing resistance to. Infections will always be there. So how can we limit the use of antibiotic, or can we limit? If we cannot limit, the best answer to tackling antibiotic resistance is by producing more antibiotics. That is not happening for obvious reasons, because it is not very lucrative for the pharmaceutical companies. So what tools can we use, apply in a proper and justifiable manner to combat this antimicrobial resistance? So bear with me, these are very vague terms, but I'll try to make sense of them. If you have to, if you have to discuss tools to tackle antimicrobial resistance, for the sake of clarity, you can break down as to tools which are based on knowledge, which are used by us, tools of diagnosis, and then tools for surveillance. We are involved in applying all of these. This can be done at a level of the drug, where we have to understand the drug and use it in a justifiable manner, or the environment, how best to make use of that and avoid antimicrobial resistance. The tools can be in a limited setting, focused setting, like in the hospital or a nursing home or a clinic. The tools can be based on a region, state, or a country-wide specific data, or at an international or a national level. So how do we put everything together? So let me discuss them one by one. All of this is based on the WHO's signal that we are looking at a grave situation of increasing antimicrobial resistance. So it laid down certain objectives as per its global plan to tackle antimicrobial resistance. The gist of which said that we don't have enough antibiotics, though we want to produce more antibiotics, the money is lacking. So whatever resources you have, please do use them in a justifiable manner. Have good intersectoral coordination, interdepartmental coordination, and bring about a program which has benefit to the patient, to the hospital, and nation as a whole. Easier said than done. So how best can we make use of it? If you look at the hospital level, like I said, all the tools which are available, which I try to break down, tools of knowledge application, diagnostics, and surveillance. Let me begin with knowledge application. So knowledge application focuses on whom? It focuses on all of us. It may not be essentially clinician. It involves even the person who enters a medical college. So if you start recognizing what is an appropriate antimicrobial therapy right now, it serves you well in the longer run. You may be a surgeon later, you may be a neurosurgeon or something else, but these are important. So you need to know what is the syndromic diagnosis, what antibiotic works best for it, and what should be the right duration and dose. So if you are able to apply, that is step one, where you can justify and properly use antibiotic and reduce the risk of resistance. So that you begin with. This is what thing does. What can make things easy? We had a discussion about the Aware tool and all the difficulties. So what WHO did was divided or broke down the antibiotics into three different sectors or classes. It said There are certain antibiotics for which resistance development potential is less. So if you want to use any antibiotic on an empirical basis to treat your patients, use that class. That is called the access group. Then there is a group called a watch group where there is a moderate potential to develop resistance. Use them if and only if the indication is very strong, you're very sure that works and there is no other option. And the last group or the reserve group, try and avoid it as much as possible. So it should be like access groups most often, watch group less often, reserve group hardly. But the situation nowadays is it's always the reserve group which goes on top and there is a red flag which goes in. But know these. I mean, time may come if at all we do good antimicrobial stewardship program. If you look at the drugs in the access group, those are all old repurposed drugs. Go back and look into the culture report. More often than not, you find these to be sensitive and useful. So maybe time might come in future, near future, where we can go back and use the access group drugs as empirical therapy. So again. So if you are more confused, if you are someone who want to clinically apply these, you want to do a justifiable proper practice of antibiotic use. If at all you're not able to go through that, there are simple websites like these by the WHO. You can just go in there, you can just type in the name of the drug. It lists the indication where it should be the first choice, second choice, what are all the alternates. So all these can be made use of, and then you can apply and see whether this works in your scenario. Don't blindly follow anything. So this should be trickled down into a local setup where you should see whether your set of patients benefit with this. But having the background knowledge always helps. Otherwise, it will be just rushing to a gun battle with a life vest on rather than a bulletproof jacket. So having knowledge is where it all begins. We can discuss a lot of things. We can discuss about stewardship and all that. But if you don't know what you're doing, it is of no use at all. So learn. So that's the first thing, first tool in tackling antimicrobial resistance. An extension to this is now you are a team leader. We discussed about the antimicrobial stewardship program. You are a team leader. You may be a clinician, ID physician, you may be an intensivist or a clinical pharmacologist who helps directly or indirectly decision making for the patient about choosing the antibiotic which is right dose, bolus dose, and all whatsoever. So you may take the lead. If you become the leader of the group, take the lead and try to follow these. You try to see whether you're choosing the right antibiotic for yourself or for other consultants. Choose the right drug, the right dose. Help them out, right? You always have the antimicrobial stewardship program to back you up. And if your knowledge is good enough, they will always respect, listen to you, and then we can continue with a good stewardship initiative. So where do you start? We discussed about antimicrobial stewardship. Yes, like I said, it is easier said than done. Where do we start? Choose things which are easier to begin with. What we have realized and what most of us HICC members realize is it's always easier to talk to the surgeons, though they are the most difficult people to deal with. Always start with simpler things like antimicrobial prophylaxis. See, when you begin to treat their patient and then give them advice about treating, it is very difficult to convince them to stop something if they have already started. So begin with some things like an antimicrobial prophylaxis. You obviously won't need a drug like meropenem to give prophylaxis for cesarean section. It was happening even in my institute, trust me. So you have to go to them and tell them, right? You don't have to use such a broad spectrum drug. Use something limited which only covers the skin pathogen and give only one dose, which is more than enough. 3 doses in some complex infection. That's all. So you begin that. If you are able to do that, you started the step 1 of good antimicrobial stewardship and good antimicrobial resistance program, which can cut down and curtail the use of antibiotics. Do the same when antibiotic is initiated. If you are someone who's been involved in the stewardship program, you always go ahead and try to do certain things which will help out the patient as well as keep the physician or the surgeon in confidence. You can talk to them. You can try and make them understand what are the benefits of de-escalation. Time and again, studies have clearly proven if you de-escalate in an appropriate manner, it saves more life, more money to the patient also. So you can always tell the surgeon or other doctor which is involved that de-escalation may not be always a reduction of the drug. It may be reducing to a narrow spectrum. It may be coming down from an IV to an oral switch, or you may optimize the dose and tell them, it is getting better. You can always come down. Like we discussed in one of the sessions, like we said, prescriber anxiety. See, the treating doctor is always worried about 2 things. One, what if the patient goes wrong? So for him, always the go-to drug is antibiotic, irrespective of whether the patient has infection or not. And if you try to take away that lollipop from him, he will always try. So don't try to be hard on him. Try to give some alternate solutions. Like we just spoke about this inhalatory cholesterol. One of the ways to de-escalate, though it is not justified or evidence-based, is One of the surgeons not ready to stop colistin IV, though it is not justified. They think it is bad, though it is not. Patient is already getting better. So we tell them, okay, give nebulized colistin for a while. IV colistin is no more required because still giving colistin, patient will get better. Trust me, that nebulization colistin will just go to the air and nowhere else. But at least we are not inducing drug resistance. Wrong things you think, but sometimes you need to be smart. So like I said, you need to have a physician-driven AMS program, sometimes which works on the basis of being smart based on knowledge. You just don't do random things. You need to be knowledgeable, but choose few things. Then we decided on IV to oral switch. You tell the nephrologists were very worried to stop IV drugs. Meropenem would go on together. When I joined, I had a patient who was on meropenem for 42 days for no reason at all. So you always give them some other chocolate. You give them some oral drug. Tell them, even though patient will not need it also, tell them a narrow spectrum oral drug. This will work as good as meropenem. You need some time to convince them and then come down. So these are strategies where from broad spectrum you're trying to come down. Antibiotic stewardship does not mean stopping an antibiotic. It's about reducing the spectrum and causing minimal damage to the patient in terms of his life and birth. And always there are fixed guidelines. There are studies which you need to constantly update. You need to know what is the exact duration of treatment. You need not treat a community-acquired pneumonia for more than 5 to 7 days. You need not treat a ventilator-associated pneumonia if the patient is getting better for more than 7 days or so. So there is no justification in using the antibiotics just for the sake of it. So if the duration is done, the patient is getting better, cut down. So these are knowledge-based tools to prevent any misuse of antibiotics. If you don't do that, like I said, if you don't update yourself, you give random suggestions which are not really based or backed with evidence, there is a high chance you'll disappoint yourself and then disappoint others also. So the gist here is constantly update and upgrade yourself and know what are the tools which are coming in. Who would help you out in this? If you are someone who's dealing with the antimicrobial stewardship program, your best friends are your infection control nurses and your clinical pharmacologists, apart from the clinical microbiology team. So you can always use them to survey. You can always use them to pass on the message. What a clinical pharmacologist do is subtly, we had a discussion about the medical legal implications of writing something. What we have done is there is a call. Call goes from the clinical pharmacologist to the treating doctor, asking him, sir, there is a doubt about this particular dose drug. You're not modified according to the creatinine levels. Would it be okay if we suggest this and are you willing to change? Trust me, nearly 70 to 80% of the time they do agree. Maybe there are some arrogant ones who don't, but it's just the beginning. And second step where they come into use is the discharge summary. If you scan through 100 of your discharge summaries, nearly 70 to 80 will have wrong discharge medication when it comes to antibiotics. So that is where we will be able to achieve some good stewardship, where the clinical pharmacologist goes through every discharge summary. He sees if there is any wrong prescription in terms of dosing and informs the primary clinician and does the change then and there. So these are certain tools, these are certain tools which are knowledge-based human factors which you can make use of to curtail misuse of antibiotics and hence combat. Vaccines as a tool to counter, it may sound a bit odd. How can vaccines counter antimicrobial resistance? The solution or answer to this is simple. That there are certain diseases, most common of which is influenza and the pneumococcal pneumonia. What happens with influenza pneumococcal infection? 90 to 95% of the cases, maybe pneumococcal more than that, you hardly can prove it on a serology or on a culture. You only suspect. And we all know that with influenza, with pneumococcus, more complications follow. There are secondary infections, secondary bacterial infections. What happens is lack of diagnosis always triggers antibiotic use. And if there is unnecessary antibiotic or a wrong antibiotic, these tend to go on and on and on. And what happens is more antibiotic get added on. So if you focus a program which may be hospital-based or a region-based, where you're giving a good strength of numbers in terms of influenza vaccination, pneumococcal, maybe TDAP also. So that's what I focused on vaccination. So what we do is we have chosen our cardiology and surgical patients. We choose the group like diabetics, like CKDs, like long-standing CLDs. We have already discussed with the consultants that at the time of discharge, if you are able to give influenza vaccination and pneumococcal to limited indications in certain group of patients, the future complications will come down. If it is driven through the primary consultant, trust me, it works. So if you can reduce the burden of these diseases, you can reduce the burden of secondary bacterial infection, and hence the misuse of antibiotic can come down. This is, like I said, it's a small thing to start off with, but if it catches on and then becomes big, can be one of very essential and useful tools to tackle antimicrobial resistance. Most important, none of this would be possible, whatever we are discussing, in the absence of appropriate diagnostics. So when I say appropriate diagnostics, most ideal diagnostic test is something where patient comes in with a clinical syndrome, you're diagnosed saying, okay, this may be community acquired pneumonia, UTI, meningitis, so on and so forth. So you take a blood sample or a tissue sample, drop it into a well of diagnostic test, and then say in a very short time you get the result and you know what to treat with. Why it would be so simple for us and for the patient as well. You don't have to misuse antibiotics. But unfortunately, that doesn't happen. In the current day scenario, what we deal with is a patient coming in sick, we trust blood culture to give us the result, the sensitivity of which is very less, right? Also, it is time consuming. So you have a culture, you load it to the bottle, if you do it in an appropriate manner, goes on to the automated system, then identification may take as less as 12 to 20 hours, but still that's a huge number. Then for identification, drug sensitivity testing, it may take another 36 or more hours, by which time we have literally used and abused antibiotics. If we can cut short that duration, so what are the things which can help us do that? We have the Film-Array, which is an FDA approved test. That is one thing we make use of. We have Manditop, not many centers have it though. Problems here are these tests are costly. They add on to the cost of the patient. Even though you can discuss the cost effectiveness, it is not so easy to convince physicians to use them all the time. And these are tests which are always culture dependent. That means you need a positive culture for these tests to be working. So that is the biggest problem and drawback. So at this point of time, even though we can talk about diagnostics, the diagnostics are not as robust as we want them to be, and they are not as pure or targeted as we want them to be. So can there be a change? Do we have anything else which we can do about? So at this point of time, there exists a test called T2, which is a magnetic resonance based test, which is FDA approved, and now started off in US nearly as a trial basis. It has proven and shown to reduce the identification time to 3 to 5 hours. That is, you take a blood sample and you can identify these set of organisms, fungi, bacteria included, and guess what? More to this, you can also identify the resistance. So this would be an ideal scenario. So in 3 to 5 hours, you have the bug, but it is now limited to few bugs. That's okay. Still, these are the dangerous ones. And then you can also know the resistance based on which you can choose your antibiotic in a wiser manner. And it clearly scores over other tests. Problem, yet to come to India. Will it take question? Because it is very costly. 60 lakh is just one-time investment, and then there are multiple lakhs involved in further investment just to build up each step of this T2. So we don't know. Time will answer whether this happens. But if this can be used in a proper manner, properly, it will add on to the usefulness of antimicrobial stewardship, and this may reduce the turnaround time and also help us to avoid unnecessary antibiotic use. Fungal identification has always been a pain because sensitivity is less, and even if it happens, it takes a long time. It may be as less as 2 to 10 days, as long as 3 weeks also. So, and it's been there forever. We only depend on fungal culture now for identification, even though there are adjuvant serological methods, adjuvant tests like galactomannan and the beta-glucan. None have been proven to be equivalent to culture, and we still have to bank on it. The problem is pickup rate is low and time consumed is more. So there are certain tests which have come up yet to be validated. Probably if that happens, that comes into picture, we may be able to diagnose a fungal organism within 1 to 2 hours and prevent unnecessary antifungal use. TB has always been a problem in terms of diagnostics. If you look at culture conversion rate, even with the best sample, not more than 30 to 40% takes 45 days or so. Tests like Expert, which are PCR-based platforms, and then the line flow batteries have made our life easier. They identify the organism within a very short time, 4 to 5 hours, and they also give us an idea about drug resistance. But the problem is they too have the problem of sensitivity, poor pickup rate. If that problem can be tackled, I think this can help. Other problem is they are validated for very few samples, like the sputum. Getting it for a sample other than sputum, it is quite difficult, but we still try, and a lot of tissues we are able to diagnose TB based on this. So what I mean to say is diagnostic which is fast, reliable, accurate, and which is sensitive enough to pick up most of the infections will be of great value in antimicrobial stewardship program and a good tool to counter antimicrobial resistance. This slide, I think, start. Don't finish fast. I discuss this finishing. Not my spell. So beyond diagnostics, what could be of help? One thing which is of great help when it comes to tackling antimicrobial resistance is use of an antibiogram. What most of us don't understand is the utility of it. What is an antimicrobial? Simple. It looks like this. You look at the organisms which have grown from different tissues, different samples over the last 1 year. You look at the drugs which have been made use of, match them against each other and see what drug has worked best for which organism and in which tissue. You can further break down and see, okay, from ICU, what is the antibiogram? What is the antibiogram of the ward? What is the antibiogram in ER or OPD? That will be of great help, based on which you can dedicate and decide an antimicrobial policy, circulate among your physicians and surgeons, and tell them, see, this bug works best against this antibiotic or the other way around. And if you want to empirically choose an antibiotic, please use this. Don't unnecessarily do other things or excess combination therapy. A good clinical microbiology team is of great value and a good tool to generate this antibiogram and also to cut down the risk of antimicrobial resistance. Doing all this, like what Dr. Riku mentioned, the essential component of antimicrobial stewardship is surveillance. He's already discussed about antimicrobial utilization. I won't spend much time on it. What is of essential importance is you track healthcare associated infection. That means patient is there with you for more than 48 hours, develops some new thing, maybe line related, ventilator related, or catheter related. You need to know how many of them developed so, how many of them developed for what reason, and was there any poor bundle compliance due to which they developed these infections. If you're able to track them down, understand the deficiencies in your care, you can always go back and explain to your critical care team, your surgeons, and others to tell them where we can improve things in a better way. Because if there is a healthcare associated infection, all we know, more often than not, or almost always, these are drug resistant organisms which are responsible for it. And if your infection control practice is poor, what happens next is one healthcare associated infection passes on to one patient and thereon, so on and so forth, sometimes leading to outbreaks which may or may not be recognized at all. So tracking these are of vital importance and ensuring these is of vital importance. So looking back and surveying them is of great importance. That's an essential tool for you. If you want to look at hand hygiene compliance, I mean, this is something which will never be 100% accurate. This is always subjective, but you can always try. Most importantly, like I said, there is a new infection. You have to prevent that from going from your patient to some other patient. The best way to do so is create a barrier, that is infection control practices, isolation practices, and hand hygiene. It is not enough just by doing hand hygiene. You should also know how well you're doing it. There are different ways to assess how best you're doing hand hygiene, none of which are foolproof. There are always lacunae in the assessment, but still you keep trying, keep continuing to do so. And if you're able to match up to your hospital standards of hospital hygiene and hand hygiene, you'll realize the infection rates also will significantly come down. But you also have to constantly keep track of it. What helps best is use of technology. So what we have done in our setup is, we use two teams to survey hand hygiene. One is the infection control nurses, other is the quality team, and they have tablet which is directly integrated into a system. Every moment of hand hygiene, wherever they're capturing directly goes in, it gets collected as the data, and then every week we assess and we make monthly data and we project it in our system. So this will help. Feedback is important. That's also an essential tool which will help on the physicians, surgeons, and intensivists to understand, okay, this is the rate of hand hygiene compliance and this is the rate of infection. Let's improve it or let's sustain it. So monitoring is as important as carrying it out. So this already discussed. So the DDD and the DOT, I'm not well much into it. So this is the structure. So all of us put together. So there should be a leader. Leader can be anyone, a good physician, a good intensivist, or an ID physician, or a clinical pharmacologist leads the way, along with clinical microbiologists, infection control nurses, and then other clinical pharmacologists involved. They all put their head and hands together, and then comes the AMS program, and apply all these tools which will help you all. So this is what helps at a focal level, that is a hospital or a nursing home. So this is where maximum action happens. But like I discussed with you, the problem is elsewhere. You, as a quaternary care center, may be getting a very sick patient who ends up with ICU, but you realize that the patient who's come from a tier 2 city already has a neuropenicillin before you came to you. Right? There are parts of Andhra where there are so-called registered medical practitioners who are 10 pass who administer neuropenicillin to patients before they come to you. So imagine you're doing so many things to build a house, and then there is someone who's already growing a bench from the other end. So it is required for us to convince the government. It's very difficult on our part also, but the government also understands that it doesn't stop with the hospital. We have to go beyond that. So a lot of program initiatives have been done. ICMR said, okay, you have been using antibiotics all wrong. We have the better ones will tell you how to use it. At least they came out, made some effort of it. If somebody has any doubt as to what to use for what infection, this is one of the essential tools. Today there is a webinar going on at ICMR where they're going to release a mobile app where this kind of guidelines will come into your mobile, and then you can always look into it. If you have any doubt, always compare with other centers and then go ahead and use antibiotic in an appropriate manner. Then the government also did certain things. It listed certain scheduled drugs where without prescription they cannot be used. It went one step ahead and said the red line, this cannot be prescribed without, cannot be given or dispensed without a prescription. But most of them are on paper, isn't it? So you see all of them being given easily dispensed. So it needs a consolidated effort from the government also, from the regional institutes also, and decision-making bodies to continue with what we are doing. It is not enough for all of you here to learn, go back and apply things. It has to come from outside. And WHO also realizes it. It has a global surveillance network. It encourages the countries to feed their data and then identify where the problem areas are, compare with other countries and see what we can do best. So it needs a consolidated effort, everything put together. These are all the essential tools. If and only if these are done in unison, we can go ahead and tackle antimicrobial resistance. Otherwise, we end up with where we started. And like I said, antibiotic apocalypse may be on the way. Thank you.
Sir, for that wonderful talk. Very insightful and tools to combat. I think we can. Thank you so much, sir, for that.
I'd like to request the chairperson to facilitate presentation talk. I'd like to request Dr. Rama to please facilitate our chairpersons for the session. Thank you so much. Our next session was going to be two panel discussions. Unfortunately, we are running quite delayed in our talks. So, some of the speakers have flights that they have to catch in the evening. So, what we have decided to do is have a single platform where we will be discussing both topics as a unified panel discussion. So, the more the merrier. So, instead of 4 panelists, we'll have 8 panelists. I'd like to request Dr. Panita and Dr. Rana to please come on stage so they can moderate the session. And I'd like to request all the panelists to occupy the first row in the front. Dr. Sunil Karan, Dr. Pratap KG, our Registrar of Academics and Professor of Microbiology, Dr. Santosh K. Devdas, Associate Professor of Hematology and in charge of the Pulmonary Transplant Unit, Dr. Vinay D. is already there, Dr. Sumit Rai, Dr. Deepu Satyapalan, Dr. Pradeep GCN, HOD of Hematology, and Dr. Harshit, Assistant Professor of Pulmonary Critical Care, and Dr. Bharat, Assistant Professor of Pulmonary Critical Care. Please occupy the front seat if that's okay. Thank you. Thank you so much. Over to you, Dr. Panika.
Which presentation?
So first, we discuss some case scenarios. The cases are fictitious cases, basically created to bring out possible errors that we might be making in our practice. Any of the panelists can answer this. The mic will be passed.
I like it.
Skip the intro after go to.
Do the slide.
Yes.
So we have a 35-year-old male who was admitted with sensory motor quality paralysis and impending respiratory failure, diagnosed with GV syndrome, received IVIG on mechanical ventilation. The patient developed fever on day 14 of ICU stay. So how will you evaluate this patient and what empiric therapy should be started? So any of the panelists can answer.
The first and foremost, I think I'm very impressed that the fever came only after 14 minutes. So in this case, if there is no shock and if I don't suspect that there is a major MDR infection, I would send out cultures. It should be the fine usual cultures, tracheal X-ray, chest X-ray, no shock, I would probably start with the BNP. But if it has a bacterium or serotonin surfactant to start with. If the patient also has associated shock or there is most probably only a carboperin to begin with. It will probably also depend on other comorbidities plus the fact that only the patient on either side because cross transmission is also something we need to be aware of.
Anyone else?
What Dr. Sunil Karan says, but I think we'll also look at other factors like whether line is in place. So now we are trying to achieve a syndromic diagnosis. The patient who's in the hospital, possibilities are it could be ventilator associated. We look into that, what is the possibility? We look into how long the line has been placed, whether it is a central line related bloodstream infection, whether it is catheter associated, or maybe he's having a simple phlebitis, which is triggered fever. So antibiotic choice, like Sir said, depends on where the syndrome might be originating. I think there is a stronger possibility that it may be line related. Sometimes, depending on, again, your own experience in the center, a gram positive might also come into play if the patient is a bit sicker or in shock.
So the investigations which were done for this patient, a single bottle of blood culture, the urine routine and urine culture, ET aspirate culture, procalcitonin, TLC, CRP, and chest X-ray bedside. So what do you feel? Are these investigations justified, Pradhan?
Blood culture is something that we may have to still be guarded when we do it, and we would probably like to have multiple blood cultures from two different sites. It is very difficult to differentiate between colonization versus possible pathogen. So it is a combination of what you probably isolate the clinical scoring that is available for a particular hospital-acquired infection, plus the clinical correlation in terms of how the patient is responding would probably help.
And what is the role of inflammatory markers in the diagnosis of sepsis? Dr. Bharat.
Like to echo what inflammatory markers, a thorough focused clinical examination is something which has to be done. You get your line, get whether X-ray, phlebitis, as Sir mentioned. Maybe upfront, I won't be too concerned about CRP or colistin. I mean, procal at this point in time, especially if there's no organ dysfunction.
it has value two ways. I mean, you can use it as something of a negative predictor. So if procalcitonin is not elevated, there is a possibility you may be looking at some near inflammatory to non-infective condition as a possible cause for fever. Or even if it is elevated, you can use it as a marker to assess the response. Never for diagnosis. So inflammatory markers, we should all remember, are not tools to diagnose sepsis. They may be used to or maybe used as a follow-up later.
So these are the reports. So like Pratap sir said, due to a single bottle, this is a possibility that might occur. So as you can see, we have ET aspirated pseudomonas with 30,000 CFU, and it's resistant to all drugs except tigecycline, urine and E. coli, and we have cons in blood registration. So the treatment given was meropenem and vancomycin, and think about this.
Can you show the previous slide? Got it. There is no change from the baseline. Saturation is full. FiO2 has not increased. So unlikely to be VAP or even IVAC. No pyorrhea, but then autotome is elevated. That we taking suggestive. So in order to tell that a patient has VAP or a VAC or IVAC, we need to have X-ray infiltrates for increase in the oxygen concentration, which is not there. So I am not really suspecting further about the possibility of a related associated event. The counts are elevated towards the sepsis site, okay, more than 0.5 again towards the sepsis site. CRP is not elevated, but still, since there's okay, we feel that interclinical in everything the patient has an infusion. Blood pressure story forms by waste negative step. So when I have to start with the blood culture, the way the blood culture has been sent as correlated. 2 sets of blood culture from 2 different sites has to be sent, but it is not there. And now what we are left with only by this negative stuff. So we have to take the decision whether to say whether we need to treat it or not. So for that you need to decide whether it is a common contaminant or a common pathogen. So by this negative stuff, it shows QT bacteria. All these are common contaminants. So you need not treat that. Pseudomonas, aeruginosa from the ET, but X-ray already is not suggestive of a VAC, so we need not treat that. Urine culture showing E. coli of 50,000 for the urine. More than 1,000 as per definition, 40 can happen. So 40 is something which I will consider after seeing the reports.
So this is the treatment that was given. So after the cultures, they changed to colistin and tigecycline. Meropenem was stopped and vancomycin was continued. So I'd like to ask Pratap sir what he thinks about this treatment.
One of the things when we talk about the treatment change here, the possibility of carbapenemase is one of the considerations that can we should probably think of. And clinically, if there was if the patient's condition did not improve, and if there is a progress with respect to markers of the inflammatory markers, that probably would have led to the change in antibiotics here. And another thing is here they have still continued with the gram-positive cover. So one of the possibilities here is coagulase negative staphylococci. There are different types of coagulase negative staphylococci can still be probable pathogens. So looking at this treatment change, that is one of the possibility where they probably thought of cons as a possible pathogen here.
So, Dr. Sunil, do you feel vancomycin is justified here?
Difficult to say actually. So I did think with one bottle is neither here nor there. And at this point, yeah, at least one pair. You said one bottle or maybe
only one bottle.
Yeah, so I think both of our pairs have shown and they have been. For now, since we have made the mistake of thinking to watch out all the time, repeat the concept. Remove your plastics, there is no trial. They repeat the concept, keep it going, see the connection of concept.
So if the next set of cultures come out sterile, do we assume the vancomycin has worked, or do we assume that it's not required?
Not required. Culture was taken very. Yeah, very bad. You have to correlate it clinically. During that time, if there is pain shock, you fever, then obviously you will not stop. There is a day to believe that cause is a contaminant, but we need to be aware that there are certain circumstances that cause can be a contaminant. I think it's important for the audience to take.
Discuss about syndrome. That seems to be less likely possibility. But the primary treatment is based on that.
Right.
So cholecycline may not have been necessary at all. If UTI is what was consideration, then also cholecycline may not. So again, localize the syndrome and an antibiotic should be faced.
The root cause analysis, this is what was found. So what are your thoughts on sending surveillance cultures in ICU patients?
Don't waste money.
The importance sir has already stressed on this. Scenario 2, a 76-year-old bedbound lady catheterized at a nursing home 20 days ago with comorbidities, hypertension, diabetes, osteoarthritis, obesity, non-healing right lower limb ulcer, presented with altered sensorium, GCS-10, no neck rigidity. On examination, BP is 80/50, heart rate 120, respiratory rate 24, she's able to drive. Baseline X-ray is normal, LPCT head is also normal. PBD shows lactic acidosis. So what is the working diagnosis? Dr. Bharat?
So we have an elderly lady with, who has a catheter, this catheter in situ, who has multiple comorbidities, who has presented with different signs of sepsis, tachycardia, tachypnea, hypotension, and lactic acidosis. All there is no doubt that this patient is in sepsis, but now just saying sepsis would probably not suffice. We probably need to know what the source of sepsis in this case is. The organ dysfunction here is circulatory. So it's very important to know whether she had any central line or any sort of thick lines in situ. Then again, your sensorium, again with extremes of pH, any sort of sepsis can cause septic encephalopathy quite easily. So that is something that is not very, very forthcoming in helping us to localize the source. One possibility could be that there is a police catheter in situ. So we need to know whether there is any signs of clinical signs of pyelonephritis or pyeluria, which can help us narrow down the possibility. So overall, I think maybe urosepsis with septic shock would be the working diagnosis. And as has already been mentioned by our speakers, given that there is organ dysfunction in the form of shock, and given that the prevalence of ESBL producing organisms and maybe even carbapenemase producing organisms in urine is quite high. So probably empiric antibiotic of choice would be a broad spectrum PLI, or for that matter, maybe even carbapenem at this point in time.
Dr. Sunil?
What is the baseline rating?
She's bedbound, so bedbound, not admin.
Don't beat me up on this. I think somebody who is bedbound, who is unlikely to do well, I would agree with Dr. whatever he said, but I would definitely not start carbapenem because I don't think we should expose when we go to the outcome. This patient is still tested. This is the area of disability. That's my way of doing it. But I think since this is a class of antibiotics, this is fine, but we have to look for other causes of shock also. We have to definitely go. So otherwise, the thing I will
in a patient who's catheterized for a while, we don't look at pyeluria as a criteria to diagnose UTI at all. It is expected to have pyeluria because some inflammatory response that's as soon as you catheterize. So in a patient non-catheterized, pyeluria has great pointed towards UTI, but not in a catheterized patient who is symptomatology plus minus culture.
Yeah, so the urine protein showed 15% and NCCV KUD no cystitis or pyelonephritis. The culture showed 50,000 CSV per ml. It had fractional pneumonia sensitive to nitrofuran and paired blood cultures revealed MSSC. So, Pratap sir, your take on this?
Here again, when the patient is in if the patient is in ICU, one of the things that I would like to go back and probably check on is all your checklists with your care bundles, whether your infection control practices have actually been satisfactory. That is one aspect that I would say. And second thing is the urine culture with in a catheterized patient. 50,000 coniforming units can still be significant. And here again, one of the problems is multiple causes of infection which would lead to problems here, because here, according to whatever this is indicating, it would be probably a mixed infection, but we can't rule out that MSSA can still be a probable commensal. So we should again go by the clinical scores, and the correlation is essentially going to be an important factor here. And that is why I again keep emphasizing that even when first thing is about the infection control factors, second thing is how you collected the specimens, because that goes a long way in deciding what comes out as your report. And the third thing is your communication channels to still be kept open with respect to discussions to look at how things move. And as you know, you still have to correlate with the other inflammatory markers along with these things. So a combination of everything.
We have an all-healing ulcer. So I mean, in the background of that, probably osteomyelitis, MSSA is always been there. MSSA in blood is something not to be ignored, but the very courageous to this book. And also in paired blood cultures, MSSA has come in. So more importance to that. So whether she also has EPI is a question which is very difficult to answer. So will you really start holistic? So first focus on MSSA. You have glucoxylin, that would be my drug of choice. Even the patient is sick, it works wonders. And I will not be wrong in probably giving 48 hours of holistic, see how things work. If the response is faster, you can always try and de-escalate it, because it is always one bug which predominates, and something in the blood is what is always more important. And if your clinical syndrome, you see that non-healing ulcer is badly infected, and cultures of there also shows MSSA, I think it is MSSA all the way through. I will stop holistic.
So the treatment given was colistin and vancomycin. Cloxacillin was not available.
So there's something
Some data to say that mortality is higher, but nothing other things that are linked. I think that
We have commonly encountered that vancomycin is given to MSSA when clox is not available. That's why we wanted to bring it out so that.
So I think alternatively you can use sample.
More ready.
But you take a second is quite easy level.
Cefazolin also. Reflin, its injection is we are not able to get it in our hospital actually. We don't have it in stock in our hospital. We are not able to get it.
So it is available in the market, both of them, flucloxacillin and cefazolin, less commonly. Flucloxacillin is available, and it's a very good drug for it.
In case you can just give us the brand names, it will be helpful to us.
One point to add on.
Yes, sir.
In the initial history, it was not mentioned that it is an infected wound. So from the initial history, I think the diagnosis has been suited by the so. But if it is an infected wound, then definitely from the MSSA there is a possibility. And if it is not that infected, and if MSSA is still there, then I would like to rule out the infected endocarditis as
So I'll hand over to Dr. Nada to ask a couple of questions.
One second. I just want to highlight for the audience the two cases that we've done so far. In the first case, where the blood culture was not taken properly, and how much confusion it actually led to, even in among experts. Where they know what they've had experience with this, And just the fact that the blood culture was not taken correctly led to so much confusion in the decision-making process. And the second case where the blood culture was taken properly, where there was double paired cultures, they were a lot more confident in saying this is MSSA, treat the MSSA first, and so on and so forth. Just highlighting how important it is to standardize how you take your cultures, standardize who is taking them, and get those processes in place before you can get up to the next step. Thank you. Dr. Radha, sorry to interrupt.
I also want to highlight the fact here that because you already highlighted one of the facts, I want the residents to know that clinical examination is most important. If patient has fever, we send all the cultures available. That is not the correct practice to be done. We have to clinically examine, jot down the number of differentials and then send cultures accordingly. Because only clinical history and examination would differentiate a commensal and a pathological.
And the buzzword of pan cultures, which is probably from House and Grey's Anatomy, and like pan cultures, let's do pan cultures.
For the soft tissue.
Not for bacteria. I mean, for bacteria, genome is what it is.
Another adding to his point, man, cultures and tropical doctor. Everybody thinks they know it is 20,000 bill gone in from the year. I think very important that you analyze, then don't say the whole lot of things.
We do not need broad spectrum in this aspect.
Yeah, clinical medicine still thrives. I think all of us have to be good clinicians. Okay, so that's very vital. So I'll be asking question to Dr. Santosh. Basically, he's an oncologist. What are the kinds of infections you commonly encounter in transplant and non-transplant patients? And is there a difference in your approach? And like what, as an ICU physician, I should be doing? Suppose your patient comes to my ICU.
So there is fundamental difference in a patient with getting chemotherapy. There is immune suppression, which is visible or not visible. It is visible very obviously with neutrophil count, and that is something that says that patient is profoundly immune compromised. And we are much more, it's like a medical emergency, and we are very, very careful when we deal with patients with immune compromise who come to the emergency or for inpatient. And we do ensure that broad spectrum antibiotic is used. We use the most important caveat is most of patients that we treat are not like the patients that are generally seen in the community, and so it's a different world altogether that we live in compared to all the scenarios that have been discussed. To just add to the complexity, we, as Dr. Sunil was mentioning, we are already in the post-antibiotic apoplexy era, and we lose a lot of patients just because antibiotics don't work. So we've already gone to the post-antibiotic era of using granulocytes, even before we go to the last antibiotic that is available.
Just to another part of the question, basically, in which situations you'll consider empirically antifungals, antivirals?
So a significant proportion of our patients are on empirical antifungals and antivirals even before they develop fever. Since they're not broad spectrum, prophylactic. Most of the patients who are diagnosed with acute leukemia, myelomas, lymphomas, when they start on chemotherapy, they are on antivirals of acyclovir, levofloxacin. Because there is a lot of data, I have to say that you're most likely to lose patients to infections in the first 2-3 cycles of the treatment, and once the disease comes under remission, we tend to stop the prophylactic drugs, because once the disease comes down, their immunity recovers, and they're more likely to be able to fight infections, opportunistic infections.
Is there a role for an ID physician here, apart from you as a clinician treating the patient?
Maybe we should ask the ID physician this question.
Absolutely. Maybe the take from the ID physician will be very interesting.
Sorry, Dr. Santosh, the question was like whether in your clinical practice, suppose there is an infection like this in a scenario, whether you will involve the ID physician. Now we will ask Dr. Vinay, that's fine, but I wanted to know, when as a practice.
ID physician is a little scary for us, but now I mean, there's with the ID physician who joined us, that you can control us from giving granulocytes. So we are able to be recently published, presented our data of granulocytes in the Asia Pacific bone marrow transplant meeting of prophylactic granulocytes. We're able to, we are not even going to cholesterol nowadays. We are using prophylactic granulocytes to, once they go beyond meropenem, we are using granulocytes. So that is something which doesn't come in the purview of the ID physician for sure.
So why don't we give it to the ID physician to just comment on the?
Yeah.
It's working.
We need to have an approach. So most of the time, if it is a bone marrow transplant, post bone marrow transplant patient, then we will decide what could be the possible bugs which is infecting the patient. So if it is within the first 1 month of post bone marrow transplantation, and if the patient is in the hospital, then that is the time we will suspect most of the hospital acquired infections. But after 1 month, when the immunosuppression is really going to take an action, we will start thinking about reactivation of the bugs like cytomegalovirus or tuberculosis. So then after 6 months, if the patient is coming back to you, then again we will start thinking of what the community acquired infections, as well as because of the compound immunosuppression, maybe some opportunistic pathogen like PCT, nocardia, those kind of. So yeah, I think that we will still have the role.
This
is an important teaching point.
Is this distinction really a scenario or is it blurred or like?
It's dogmatic or what is that?
It's all fragmenting, but you start thinking after a month, if somebody after 1 month, any transplant, start thinking of these things as a possibility. After 6 months, we look at one common thing. Some of the opportunities do come later also, but that 1 month, 6 months is when we see most of these. I mean, again, there is no rule.
Yeah, guides your decision.
Like, is there a difference between hematopoietic transplant versus solid organ transplant? Yeah, when we talk in terms of infections and the duration, when you say less than 1 month, or say after 1 year or more than 2 years, my understanding is that when you talk in terms of hematopoietic transplant, if there is no infection for 2 years, then it's very important. But the situations also differ. If you are talking in terms of say solid organ transplants, the initial first month we think it is associated with surgery or maybe surgical site infection or anything else because of ICU stay. Whereas the first month, the post transplant is supposed to be crucial in yours. Can you just highlight those differences?
Yes, sir. So it is the fundamental difference between solid organ transplant and hematopoietic transplant is that in solid organ transplant you get immunosuppression for eternity. Till you are alive, you get immune suppression to prevent the graft rejection. In a hematopoietic transplant, the incoming immune system, that is the hematopoietic system that you transplant, gets used to the patient's body, and the donor's immune system becomes the patient's immune system. And over a period of time, over a period of 6 months and later, we are able to taper the immune suppression. So the first 1 month is fundamentally very difficult for us because there is neutropenia. Once the counts come up and the patient goes home, also there is a immune defect that we need to be very careful about. But once you are crossing 6 months to 1 year, the risk of infection gradually wanes away, and you are
you can breathe a little bit more easy.
Comes to immunosuppressed population, I think it's more like a jigsaw puzzle, like what was highlighting. So these timelines are for real. So there may be certain kind of overlaps, but they're for real. And these are based on research and evidence over many years together. So if you think of something within a month, yes, this is what is the possibility. 1 to 6 months, this is the possibility. Reactivation. After 6 months, it's more of a community setting. So there may be certain changes here and there, but these are exceptions. And also about the empirical antifungal which you asked about, I mean, it again differs from a solid organ transplant and a hematopoietic transplant. Hematopoietic transplant, just to continue what Dr. Santosh said, that the level of immunosuppression to begin with is high, courtesy the transplant, courtesy the chemotherapeutic agents and all, compared to solid organ transplant. These are populations which are more prone to complications like mucositis. If you have a patient where there is no focus or focus is mucositis, you are giving them empirical antibiotic therapy for 48 hours or more. Patient is still not showing improvement. There you are justified in adding antibiotics. So that is where it comes into picture. Like I said, these are jigsaw puzzles. So you just fill in the blanks. So if not this, what next? And it is a fixed timeline. You just have to know the time. So that's advantage. Though these are sicker patients, agreed. But I think the knowledge base is there. If you're able to apply that in a proper manner, things work out well. More often than not. Our IT solution means can you talk to us with the nicest location.
So for all the residents, the take home from this would be that, especially in the immunocompromised, their trajectory is very drastic. So we have to be very careful. They may not have very classical symptoms or signs. Many a times it will be atypical and caused by the unusual organisms. So I, as a ICU physician or a clinician, definitely would seek ID's help. So the question would be, we are all adult physicians. We have Dr. Pradeep with us. So, sir, basically just tell us what is your experience in the neonatal ICU as per the community-acquired infections, severe and hospital-acquired infections, and what are the challenges and what kind of MDR infections you are managing, sir?
Okay, too many questions at once, but understand. So, neonatal ICU is a little different ballgame altogether, both in terms of the symptomatology and the way we approach. I think we are much more gentler or much more restrictive in the use of antibiotics, knowing very well the kind of adverse effects that we get to see very immediately after that. The first challenge we have is in terms of diagnosis. Now, we don't have a very classical, it's much more easier to walk into adult ICU and pick up sepsis. For me, the newborn sepsis, one of the symptoms could be just my nurse telling me, sir, somehow this baby is not looking good, could be an earliest sign of sepsis for me. Nothing objective. Go there, the SATs are good, the heart rate is good, perfusion is good, but the sister says, no, doctor, I'm not happy. Somehow this fellow isn't behaving well. To me, if I miss that and later on when they come back in the evening, this fellow would be having shock, he could be very well bleeding, and next 24 hours I could even lose this baby. So I need to be very alert. The symptoms are very subtle. I need to have my sixth sense working all the time, maybe a very high index of suspicion. But at the same time, my second challenge would be in terms of how do I diagnose? My problem is nothing comes out to be very positive or very objective for me. For you, it's very easy. The screen comes positive, your plate cultures comes unwantedly positive. Many times you don't want also your cultures are growing. For me, even when I want my cultures don't grow. That's my challenge there. So it's like if I get culture homework, which baby's culture is positive. That's an exciting news for us to see that one culture, because we don't get to see culture positive. Various factors. The load of bacteria is less, the prior antibiotic use, if the mother has already received, for me, when the mother has received antibiotics, the baby's culture would come out with sterile if it's early onset. Yes, and then the second thing for us is, so what do I rely on? My clinical features are very subtle. My sepsis markers are all, looks perfectly fine on day one. The counts are normal, the differentials are normal, CRPs just are on borderline, and I still don't have anything objective to tell me. And going back culture positivity, yes, again for us, we are sort of very stingy in drawing blood. You can draw 5, 10, 15 ml, and you can keep repeating pan cultures, pan screenings, you can do whatever. For me, if I look at one culture and the lab calls me for a repeat sample, my nurse would be like this, on to send a repeat sample. And it's okay. So the lab wants it, you do it. So it's very difficult to get a good sample in a, today I have a 540 gram baby and like culture. She's looking at me like saying, won't we draw 1 ml blood in this baby? Like, unfortunately, yeah. So the culture also becomes challenging. And one of the things that we do have noticed that when you are little stingy and you just say that 0.5 ml just to make the blood look a little pink or the culture water look a little pink, it doesn't grow. You need to at least have 1 ml of blood. And I think that will, with a good the current generation of bacterial cultures, I think we are able to get. The problem with me is the clinical pictures settle, the screens are not very good, the cultures are borderline, so everything falls back on. This is where I would say the clinical medicine comes truly into picture when you are in unit ICU, because nothing is helping you to decide what to do. So we do end up starting on empiric antibiotics based on our experience or based on our. So what we usually tell our residents or when we are teaching other units also is to look at their own cultures. There's no standard cholesterol, cycline, this, that. No, I cannot generalize my antibiotic policy on any other unit, because I know unit where there are rampant fungal sepsis. I know unit which has a lot of staphylococcal. I know unit which are dealing with meropenem resistance. I know unit which are dealing with ESBL. So there's no point in me telling, okay, this is what I do and you also do the same. In neonatology, we say, please go back to your own cultures, see your last 6 months, 1 year, pull out all your organisms, decide what you think should be your reasonably narrow empirical antibiotic that we need to initiate. But we also teach our residents how enthusiastic or how aggressive you are in starting, but please be equally aggressive or more enthusiastic when you stop. Maybe 48 hours later, you find this was a false alarm. Be more enthusiastic in stopping the antibiotics. I think that's the way neonatology is slightly different from property and adult vaccine.
Like to weigh in over here, like I would agree. I was previously I was in the pediatric institute, and one good thing about was in our institute was that the residential area was next, very close to the hospital, so close that my laptop would catch my home Wi-Fi. So one good thing about him was that he's right. We all our units are outborn, so they used to get a lot of infections from the community into the hospital, and many of them we did grow CREs. I was just mentioning the advantages of having a residential proximity of the lab with the hospital is, and of the residents and of the consultants is, like we used to get a bottle from the NICU, just barely pink in color, and even that if you put in the battle at 12 o'clock, used to flash positive at 6 p.m. in the evening. At 6 p.m. we used to make a gram stain, tell them that this is what is growing. Usually we had a lot of gram negatives growing. We used to put up a direct AST then and there itself, and then at night at 11 o'clock after having dinner, we used to take it around the lab. At 11 a.m. I used to give a call to the NICU SR that this is you can give. By 11 o'clock, there's some preliminary report they had. And at 11 o'clock at night, I used to put the white egg with the extended panels of chlorophenicol also, which was not there in the white egg panel. And by morning around 9 o'clock, we have the final IDST report. So in less than 24 hours, if the lab is, if there is 24-hour lab, then we can diagnose the infection critical case like NICU. So I think the proximity of the lab, the 24/7 lab, is an automation, of course, it's the absolute requirement for diagnostics in unit level.
Sepsis, it said speed is life. I think what sir is telling, I mean, even me and Parinita were speaking with sir during the tea break. So it is possible. I think it is the mindset. So clinician in us always have to be alive. And even whether it is neonatal or adult, I think the principle is, again, clinical medicine. Please, all the residents, make it a point, you be good clinicians. Yes, definitely in adult ICU, we have some support from the molecular diagnostic, cultures, imaging and all. But please, always make sure that you are a good clinician.
I think a couple more points that I want to reiterate what Dr. Pradeep said. Customization is important. You need to know that one size doesn't fit all. And for that, you need data. Like how he said, you need data-driven decisions. So fall back on data, have systems, have robust systems where you capture the data and use that data for your clinical decision making.
So let's move on to scenario number 3. So 56-year-old female, type 2 diabetes mellitus, hypertension, CKD on hemodialysis, fever with vomiting, followed by respiratory failure, required ICU admission. So on examination, SpO2 was 80% on room air and required N90, PP was 150/90. So mixed acidosis, respiratory and metabolic. Anemia was there, and the possibility of fluid overload was considered.
and dialysis was given by a leader which was inserted 2 weeks ago. So this is multifocal consolidation which was seen on the X-ray. So the patient was diagnosed with severe CAP, but she was not producing sputum. Blood culture, both central and peripheral lines were sent, and empiric therapy of piptaz and azithromycin was started. So do you agree with this choice of empiric therapy based on the scenario?
No doubt, severe ability of pneumonia, multifocal consolidation, kind of an immune alternative because it is CKD on dialysis. So the catheter is in place, you have a visible lung respiratory movement. But the patient is not in shock, right? So that is one thing. Next thing. Now again, so we fall back on the antimicrobial stewardship approach. So this is the patient on dialysis as community acquired pneumonia. The first question you asked is there any antibiotic exposure in the previous few weeks to few months? Is the patient in shock or otherwise? That's what we've already been discussing. In this case, there was no shock. Assuming that there is no exposure to any sort of antibiotic, so you can be very focused because it is dialysis patient DMCKD. You look at the probabilities of infection. This could be some sort of a post-influenza pneumonia and could be a bacterial process which could be pneumococcus or even pseudomonas, which are the most common to follow influenza. That way, you're justified in adding 5% as a factor because you're covering pseudomonas. It's a patient with diabetes and CKD. And piptaz chloride extract is also covered pneumococcus. The common organisms are covered. The patient is also a diabetic, 56-year-old. You also have to start thinking about the atypical organisms. So adding the azithromycin or doxycycline would not be wrong. At this point, I would say this is an optimal antibiotic choice to make.
I completely agree with Dr. Mani. But if I want to consider, the first differential can be there. If I want to consider another differential, then because of the background of the patient being dialysis dependent, being a catheter in situ, some kind of catheter associated bacteria also we consider, especially because since there's an intravenous device, the ambulatory infection in the blood, septic thromboembolism, that is another differential we need to consider. Sir already said multi-global involved. So first differential, the antimicrobial pneumonia. Second differential, endocarditis with septic thromboembolism. Septic thromboembolism. Of course, hypertension is not that, so that is pointing more towards the community, but still, I will consider that as the second differential.
Blood culture was sent. MRSA was diagnosed. The central line beeped at 3:30 p.m., but the peripheral line had beeped at 2:58 p.m. Dr. Sumit, what do you think could be the reason for this?
So you can say that if time difference is less than 2 hours, so definitely it is a CRBSI. So it is CRBSI.
So if we would consider it as a CRBSI, the peripheral line has beeped before the central line is.
Peripheral, okay.
At 2:58 p.m.
Okay. But again, yeah, in that case, the peripheral line is beeping before the thing. Then I don't think it's CRBSI. I think like already quite long.
I think it's most significant. They have a peripheral line. So you're ruling out the possibility it's not just mere colonizing the central line. It's something which probably started off from the central line, and then it is gone on through the system after. So this can very well fit into the definition of the CRBSI.
So should the central line be good?
Now it depends on what is the purpose. So now it is doing MRSA. So guidelines, when you go, clear-cut guideline, MRSA 9, yes, you should remove it. Practically speaking, you should look at the responsiveness to antibiotic over at least 24 to 48 hours. If your patient is influent, you have no other options, and you have to retain the line. I would still give that as an option. If there is an option of replacing the line as per guideline, I am justified to take off the line after replacing it with the other line.
no, it's only from a infection control perspective and as a data. But for management, I don't think it matters anyway.
What I will about that if the video people don't have access, then it becomes. I think changing or not, you have to look at that also. Are we likely to get a line color in the future or no? Based on that.
So definitely we can give it a try without removing the cell. But after 72 hours, if there's persistent positivity, that is the time you need to consider removing the cell. And if the patient is clinically deteriorating, in spite of the appropriate, there is another scenario that we consider removing.
So as Dr. Deepu rightly described, septic ammonia consistent with bloodstream infection. Ecoplanin was added to meropenem. Ecoplanin was added to meropenem. However, the patients succumbed due to progressive respiratory failure. Do you think that the initial therapy was not with us and it was ecoplanin and meropenem would have changed the outcome? Just your thoughts. Also for MRSA, what do you think is a better drug?
From a TKPD perspective, probably bacteremia is better to use.
We have seen the breakpoint to MIC quotient overall, and if we see the weighted percentage of breakpoint to MIC quotient between vancomycin and teicoplanin, the ratio for teicoplanin is much higher. Basically, what I'm trying to say that if you see the weighted ratio of all the MRSA isolates, MICs, against the susceptible breakpoint MICs, we find that the teicoplanin breakpoint MIC quotient is much higher for against the vancomycin. So in this case, probably now we are actually promoting more of shifting towards teicoplanin and vancomycin because the overall concentration of the teicoplanin received as per standard doses is much higher than the MIC which is normally attained. Again, if you compare with vancomycin that is just above the MIC, teicoplanin is way above the MIC. So again, I think for better response, teicoplanin would be, I think, a better choice than vancomycin. We do, considering this point in serious cases, we do give and suggest teicoplanin instead of vancomycin.
Sir, in this case scenario, is there any role for the molecular panels to aid a clinician bedside that can make a significant change?
When, as far as information to clinicians based on investigations which is going to help bedside is something that is not immediately available, but like was pointed out earlier, if you have a situation where you have your surveillance cultures or your reports showing that there is evidence of vancomycin resistance, maybe even a visa present there, and when the patient is not responding, there is a possibility to think in terms of other alternatives other than vancomycin. So your, like Dr. Pradeep mentioned here, your surveillance cultures of whatever is in your ICU menu, whatever is the data that is available can be a guide here. Otherwise, even a genetic marker is not going to be.
It's always enthusiastic.
I just want to know what is the current status of that time to positivity in the current context? We generally don't interact with you. Take one question.
And current positivity status, we still don't have enough data there for us to talk in terms of what exactly happens in our situation there. Because we have recently moved from manual to backpack. As far as concerned, we have recently moved to automated systems where I use Wi-Fi. So for us to give you an answer exactly with respect to our still like to wait for data analysis to come back to you with respect to the kind of others. Otherwise, with respect to your there's a lot of information available in literature with respect to that, but I would still not like to comment. Here again, you're going to have variable factors with respect to towards whether our processes are strong enough, to match with what literature says. That is why I'm refraining from telling you that in our setup, what is going to be the time to quality. Otherwise, there's nothing more. We were coming try to restart the IQ rounds which we were doing earlier, and take it on from there. Right now, we will only take the time that we start accumulating our stop worrying about that. Look at guidelines. Now, just like if you blame the centenary therapy responsible for mercy, insurance becomes a huge issue. So you have to objectively prove. If you had culture from a peripheral line and the central line, and EDP was more than 2 hours, the clinician can always say it is not central line related, so the patient's insurance will continue. So that is the essential core basis to these guidelines. From a clinician perspective, managing the patient, EDP hardly has any role. So you just will retain the line and look at the necessity. Like I said, these are patients on dialysis for the nephro team. Catheter is equisant. They won't even touch it. If you tell them just because there is MRSA, remove the line, they won't call you again at all. So you always have to look at the clinical progress. Patient is doing well on antibiotic, you can retain the catheter. But like Dr. Deepu said, patients worsening, repeat cultures are positive, then you are really justified in pulling out the line. Don't use DTP as a criteria to pull the line. Treatment remains the same. Go by clinical picture.
So we'll be ending this integrated 2 panel sessions. I would like to thank on the organizing committee all the esteemed panelists for being there. It was very insightful. So the bottom line is, please send the samples adequately whenever it is appropriate, and make sure that clinical examination is done adequately, and always look for the other causes of fever also. It may not be infectious also. Please be judicious. Thank you.
Thank you, esteemed panelists, for an interactive discussion. Thank you, Dr. Radha and Dr. Parinita, for chairing the session. I now request Dr. Divya Prabhu, Associate Professor, Department of General Medicine, to kindly give the vote of thanks before we end this hearing.
Respected dignitaries, chairperson, faculty, everyone gathered here, good evening. It is my privilege to propose the vote of thanks for today's event. For the wonderful time that we have spent here in the past few hours, which has been so enriching, it is our duty to express our gratitude to all these people who make this possible. I, on your behalf, would like to thank our Chief Patron, Dr. Ramaiah sir, for his vision and his commitment. I would also like to thank our co-patrons, Dr. Shalini ma'am, Principal and Dean, Dr. Harish, Associate Dean, and Dr. Gurudev sir, President RMH, for their guidance and encouragement. I am indebted to all the distinguished guests and speakers and panelists for accepting our invitations and sharing your expertise and time. I also thank all our session chairpersons for the capable way in which they moderated the sessions. To the organizing chairperson, Dr. Sheikh Mohammed Aslam sir, HOD of Medicine. To the co-chairpersons, Dr. Ramesh, Head of HICC, Dr. Harshvardhan sir, Head of KMSP. I thank you, sir, for your motivation and support. Successful culmination of today's gathering owes much to our organizing secretary, Dr. Sandeep Reddy, and organizing committee, Dr. Radha ma'am, Dr. Parinita, and Dr. Sandeep. Thank you for your effort. I also thank who labored hard for today's proceedings.
I owe special gratitude to all the non-teaching staff, technical and administrative staff, with special mention to the infection control nurses, Ms. Sunita, Ms. Sheetal, and Ms. Neetu. Our secretary, Ms. Uma, Ms. Radha, Ms. Shubha, and Ms. Directory. Our EDP section, Mr. Ravi, Ms. Shweta, Ms. Vaishnavi. Our office staff, Mr. Raghu and Mr. Manju. Accounts team, Ms. Deepa and Srinivas, Mr. Srinivas. Purchase team, Ms. Pranila. Designer, Mr. Ganesh. I also thank Dr. Parichay, Dr. Prasanna, and Dr. Sunil Patado for their support. Special thanks to our sponsors, Biomeru, Orthoclinical Diagnostics, Arjo Huntley, Nidus, Microlab, Diversity, Dr. Schumacher, MSR Pharma, 3M, Zenith, Bhuvaneshwari Enterprises. I would also like to thank Dr. Taranath and Dr. Megha. Lastly, I wish all the people participate overwhelmingly both in person as well as online and help in making this event a success. Ladies and gentlemen, thank you for this wonderful evening.
Thank you, everyone. If anyone is interested in the quiz, you can sit back. If anyone has flights and they have to leave or other engagements, thank you so much for attending.
The organizing committees to come on the stage, the medicine department also.
Go ahead.
Then why are you pushing me down there? ನೀವು ಆರ್ಗನೈಸಿಂಗ್ ಅಮ್ಮ ಬಂದ್ರಿ Thanks.
It goes now.
We'll be starting the quiz now. Thanks. Thanks to God.
Counter, delegates collected the registration counter.
Suhail and now ಸುಮ್ನೆ ಮಧ್ಯ ಇಲ್ರಿ ನಂದು ಆಕ್ಚುಲಿ ಎಂಟ್ರಿನ ಮಾಡಬಾರ್ದು. ಇನ್ವೈಟ್ ಇಲ್ಲ all the come on to the desk. It was really wonderful, actually. I think Sohail and Srivastava did all the work, including so I was just a part of it. Okay, all the very best. It was really inspiring that all the medicine have qualified. I think only one teacher is free. You should see them and